Um, Good afternoon, everyone. Today I'm presenting the case of a 4-month, 6 days old male baby hailing from Hunsur. Informant is mother and she is reliable. Admitted on 12th of September 2021 and examined on 18th September, 6 days later. Presented with the chief complaints of fever since 9 days and cough since 9 days. History of presenting illness. The child was apparently normal 9 days back when he developed fever of moderate grade, for which the mother took the baby to the government hospital in KR Nagara on the same day and was given medication for the same for 3 days. Fever relieved on taking medications 3 times per day for 3 days, and after stopping the medication, the child still developed fever again and was brought to Chelwamba Hospital. The child was active and playful between the episodes and not associated with rigors. Baby also had cough since 9 days, insidious in onset, gradually progressive, relieved on taking medications, with no history of post-assay vomiting, disturbed sleep, no diurnal or postural variations, associated with hurried breathing since 7 days. No history of running nose, ear discharge, loose stools, vomiting, wheeze, grunting, noisy breathing, irritability, excessive crying, refusal of feeds, bluish discoloration of extremities, convulsions, contact with TB patients or any other person with chronic cough. Course in the hospital. The child was admitted to Chelwamba Hospital on 12th September and was put on IV medications, and the symptoms have reduced since then. Past history. No history of similar complaints in the past. No history of previous hospital admissions or surgeries. Family history. No history of similar complaints in family members, and there is no history of TB or COVID-19 in the family members. Antenatal history is uneventful. Natal history. A full-term normal vaginal delivery at Government Hospital, KR Nagara. Baby cried immediately after birth. Birth weight was 3.5 kgs. No complications during birth. Neonatal history. Breastfeeding initiated within 30 minutes of birth. No prelactal feeds given. Meconium and urine passed within 24 hours. No history of any NICU admissions. Developmental milestones are achieved appropriate per age, and DQ is 100%. Vision and hearing are normal according to the mother. The child is exclusively breastfed, and it is breastfed for about 10 times per day, including night feeds, and breastfed for about 20 minutes and 10 minutes at each breast. Urine output is good, and the baby sleeps well after each feed. The child has adequate diet. Immunization is up to date according to National Immunization Schedule, and no optional vaccines were taken. Socioeconomic history. They live in a kacha house. Overcrowding is present. Father is a mechanic and they belong to class 4 according to modified BG Prasad classification. Indoor air pollution is present and father is a smoker. KP is satisfactory. Summary after history. A 4-month, 6 days old male baby, second born out of non-consanguineous marriage, full-term normal vaginal delivery, belonging to class 4 BG Prasad classification, presented with complaints of fever since 9 days and cough since 9 days. With adequate diet, achieved all the age-appropriate milestones, immunized till date, and has precipitating environmental factors. I'd like to think of lower respiratory tract infection. Physical examination. Here is a male baby, conscious, playful, and alert, lying comfortably on mother's lap. Vitals are stable. 98 degree Fahrenheit in axilla temperature. Heart rate 148 beats per minute. Respiratory rate is increased 67 cycles per minute and tachypneic. Capillary refill time less than 3 seconds. Anthropometry is within normal limits. These are the growth charts I have attached, ma'am. Head to toe examination, normal findings were present. Systemic examination, upper respiratory tract, no nasal flaring, no defects, no discharge or bleeding. Sinuses, no tenderness noted. Oropharynx appears normal and no congestion. There is no ear discharge. Lower respiratory tract infection. Shape of the chest appears normal and bilaterally symmetrical. Chest movements are equal. Trachea appears to be central. No deformities in chest wall. Apical impulse is seen in left fourth intercostal space along left midclavicular line. No scars or sinuses, engorged veins. No chest retraction. No use of accessory muscles of respiration. Palpation. No local rise of temperature, tenderness. Trachea is central in position. Apex beat is in the left fourth intercostal space along left midclavicular line. Chest movements are equal bilaterally and vocal flamettus could not be elicited. Percussion could not be elicited. Auscultation, normal vesicular breath sounds heard. Bilateral air entry is equal. Crepitations heard over all lung fields. Other systems, no abnormality detected. Provisional diagnosis, probably a case of lower respiratory tract infection, most probably bronchopneumonia. Belongs to pneumonia class according to WHO classification. Thank you.
5 minutes for presentation.
Okay. Pallavi, that was good presentation. She has just finished within 5 minutes, no? Meghana? Dr. Meghana? She has finished within 5 minutes.
Yes, ma'am.
Okay, fine. Pallavi, that was a very good presentation. Go
Thank
back
you,
to your first slide.
Yes, ma'am. Yes, ma'am.
So this is a 4 months, 6 days old male child. Next
Yes,
slide. He has come with fever and cough. Next
Yes,
slide. So now when you're sitting in the OPD and you get a child with fever and cough,
Yes,
what is running in your mind? What is the diagnosis? Only with fever and cough.
Ma'am, only with fever and cough, I could think of any respiratory tract infection. It could be upper respiratory tract or a lower respiratory tract infection. Ma'am.
How do you differentiate between an upper respiratory and a lower respiratory tract infection?
Ma'am, usually in lower respiratory tract infection, there would be productive cough and there could be use of axillary muscles of respiration. There could be chest retraction, grunting, noisy breathing would be present. These would be usually absent in an upper respiratory tract.
Yeah, we are in the history, no? And child is just 4 months old. He may not bring out sputum. So productive cough, we cannot relay. Then intercostal retraction, we cannot. That is not specific for LRTI. So your flaring of LNSI, grunting, all that is more of your examination finding. History, what is it that clinches the diagnosis of lower respiratory tract infection? Most probably.
Noisy breathing.
Noisy breathing, see, it can be even a little bit nasal stuffiness in URI can also produce noisy breathing.
Yes, ma'am.
So what is it very clinching towards a lower respiratory tract infection in history? Because sitting in the OPD, you have to differentiate whether this is upper or lower respiratory tract infection. You said that, but be specific.
Yes, ma'am.
Hurried breathing is very important. Hurried breathing and chest retraction. These two are the things which will tell me that it is probably a lower respiratory tract. In this slide, you have written child is active and playful between fever episodes.
Yes, ma'am.
So what does that tell you?
It tells it could be of viral etiology because usually in bacterial there would be toxic septicemia.
Yes.
Could be.
What are the common viruses which cause pneumonia in a 4 months old child?
Ma'am, respiratory syncytial virus, parainfluenza viruses.
What are the common bacteria which cause infection in this age group?
Streptococcus pneumoniae, Haemophilus influenzae, Staphylococcus aureus.
Go to the next slide. Next slide. Cough. Okay. And why did you take this negative histories? Could you just briefly tell me?
Yes, ma'am. Ma'am, running nose, ear discharge for upper respiratory tract infection, loose stools and vomiting for any other foci of infections present, wheeze, grunting, noisy breathing for low, if it's any severe lower respiratory tract infections, severe pneumonia, irritability, excessive crying, refusal of feeds, bluish discoloration of extremities and convulsions are the danger signs, ma'am.
Yes.
And contact with TB patient or any chronic cough patient could be an etiology.
Okay, when do you suspect tuberculosis? What should be the duration of illness to suspect tuberculosis in any patient?
Ma'am, chronic cough, more than 4 weeks of cough, persistent cough.
No, according to your national NTEP, what should be the duration of either fever or cough to suspect tuberculosis?
2 to 4 weeks. More than 2 to 4 weeks.
No, it's not a range. It is more than 2 weeks. What is definition of contact with TB patient?
Contact with TB patient with any patient within less than past 2 years.
Living with the child in the same family.
Living within the same family.
Household. Yes. Next slide. Examination slides.
Yes, ma'am. Yes, ma'am.
Yes. Now you go to the previous slide. He's vitals. Now this child you said has a heart rate of 148. What is
Yes,
your
ma'am.
impression of that 148? What is
Ma'am,
tachycardia for a 4-month-old child?
more than 150 beats.
So he is having tachycardia. So what do you think is the cause for tachycardia in this child?
Ma'am, it could be due to fever.
He doesn't have fever, no?
Now,
Temperature
now
is
he doesn't
normal.
have yes, ma'am.
But now he doesn't have fever, but he is having tachycardia. So what is the
Maybe
cause?
maybe because he might be having hypoxia, so to compensate for
Yes.
that, there could be increased outcome.
Yes, it may be hypoxia also. Okay, where did you look for capillary refilling time in this child?
Ma'am,
Site
soul,
in the soul your blood.
soul.
Okay, next slide. What is tachypnea for a 4-month-old child?
More than 50 cycles.
What is the
per minute,
respiratory rate?
more than 50 cycles per minute.
More than 50. Why anthropometry is important in a pneumonia child? Suppose he had SAM, severe acute malnutrition.
A pneumonia child would lose weight usually, and it could lead to malnutrition, and it would be a vicious cycle. So there would be development of SAM, one thing, and it could be also be seen in low birth weight child. And all
now it is SAM. Now he is having severe acute malnutrition. That could be a cause for pneumonia.
Cause for pneumonia.
Can you what organisms are more common? You said some organisms, no? Some viruses and some bacteria.
Yes.
In a SAM child, which organism is more common?
Pseudomonas,
it's the same organisms.
Klebsiella, Pseudomonas.
Something more specific in a SAM child?
Staph aureus.
Staph aureus is common. Staph aureus is common in a severely malnourished child.
Yes,
so what are the clinical features of a SAM child? Of a staph pneumonia?
Ma'am, it would be very severe pneumonia. So chest retractions would be grunting, noisy breathing, grunting.
So it's a severe pneumonia. Any other specific features of a staph pneumonia?
Not sure. No.
Okay. What complications are common with staph pneumonia?
Ma'am, lung abscess, empyema thoracis.
Rather than lung abscess can also occur, but more common is empyema. Empyema is common. X-ray feature of a staph pneumonia? Something very
consolidations
specific?
and air bronchograms.
That is there in all pneumonia. Something which says that this could be more towards staph pneumonia. You heard of pneumatocysts?
Yes.
Pneumatocysts? Yeah, that is quite specific for staph pneumonia, though you can get in other causes also. Yes, next.
Okay.
Go for your diagnosis. Respiratory system examination. Yes, in respiratory system examination, it's good that you have done an upper respiratory tract and a lower respiratory. So always look for upper respiratory. Why we should do a upper respiratory tract examination in already history-wise you have diagnosed pneumonia. Still, why he already has tachypnea? Why still I should look at the upper respiratory tract?
There could have been there could be a multiple focus infection, and it could have been a hematogenous spread.
Means you elaborate on your answer, like example. Multiple focus of infection means 1 more minute. Okay, thank you, Meghna.
Yes. Ma'am, there could have been a pharyngitis, laryngitis, or like a croup could have been there. It could have spread to the
Then otitis media. Otitis media
yes,
predisposes to pneumonia, sinusitis. Although in this age, sinuses, you don't look for sinus tenderness in a 4-month-old child. They develop only after 4 years of age. Yes, next. Next, go for your diagnosis.
Yes, ma'am.
So you said your diagnosis is WHO classification as pneumonia.
Yes, ma'am.
Can you please tell me WHO classification of pneumonia?
Yes, class 1 is no pneumonia. There would be only cough and fever. And class 2 is pneumonia, which has cough, fever, and chest retractions may be present. Tachypnea would, hurried breathing would be there. And class 3 is severe pneumonia, which has all the danger signs also present.
Yes. Okay. How do you manage it? Tell me one investigation you will do in this child.
Ma'am, chest X-ray. Then
So suppose if the option for chest X-ray is not there, or do all cases of pneumonia need a chest X-ray, or can I go ahead with the treatment?
no, we can go ahead with the treatment like in as per the ARI classification.
Yes. So what is the treatment for pneumonia as per ARI classification?
As per ARI classification, we can give benzyl penicillin 25,000 to 50,000 international units per kg per day. Gentamicin can be added, and or cotrimoxazole also can be given. 5 mg per kg, trimethoprim and 20 mg per kg.
You want to give oral or you want to give IV in only pneumonia? There is only pneumonia. There is no severe
only pneumonia we can give oral.
Oral what drug?
Oral cotrimoxazole.
Now it is changed. It is amoxicillin. Okay, thank you, Pallavi. Thank you.
Present a 6-year-old female who is hailing from Navalgund, informant being the mother and who is reliable. Chief complaints being complaints of swaying while walking since 2 years of age, has aggravated since 15 days. Complaints of deviation of the neck towards left side. Child was apparently all right 2 years ago. Then the mother noticed swaying, which was insidious in onset, progressive over the last 5 years, with no improvement in the symptoms, and complaints of increased swaying from the past 15 days. There is no complaints of falls. Also, complaints of deviation of the neck to the left side since 15 days, non-progressive with no aggravating factors, not associated with pain, no restriction of movements of the neck in other directions, no deviation noted during sleep. History of slurring of speech gradually progressive since 2 years, associated with low tone with unclear pronunciation, but was unable to communicate the meaning. Next. Child can walk without support with both feet wide apart with swing. Child is able to eat food with hand by herself. Noticed change in the handwriting in the form of bigger letters and not in one line. History of upper respiratory tract infection present. No history of trauma. Able to lift the hand, arm above the head. Able to comb the hair. Able to mix food and dress herself. Grip footwear without slipping. Able to lift the head from the bed and sit from supine position. Not able to climb upstairs due to swaying. No history of loss of consciousness of seizures, able to perceive temperature of hot and cold water, able to perceive the pain, no history of bladder or bowel involvement, no history of abnormal eye movements or squinting, no history of drooling of saliva, collection of the food in the cheek, deviation of the angle of the mouth while eating, no history of hearing abnormalities or tinnitus, no history of nasal regurgitation or swallowing difficulty, no history of deviation of the tongue to one side, no history of spinal deformity or foot deformity, no history of involuntary movements, no history of abnormalities in the eye or dryness of the skin, vision problems, no history of headache, vomiting, diplopia, no history of fever, vomiting, diarrhea, rash, and no emotional ability or behavior problems. Past history, there is history of 3 admissions. First one was at 2 years of age for swaying at Hegde Hospital in Bangalore. Blood investigations were done and said to have movement disorder, which was hereditary in nature. Second was 1 year back for fever and ear discharge. Third was 6 months back for fever. History of multiple OPD visits for cold and ear discharge. This is the family history. Next slide. History of similar complaints in the elder brother. Elder sibling was normal till 6 years. Symptoms of swaying, frequent falls started at 6 years of age. Had slurring of speech, non-ambulatory without support, not able to eat by himself or self-care. Diagnosed as hereditary ataxia at 6 years of age at Hegde Hospital. Next slide. Antenatal and birth history were normal. Next slide. Developmental history, gross motor was 75%, fine motor 66.5%. The rest of the developmental history is normal. Immunization history is up to date, and diet history, there is a deficit of 430 kilocalories and 3.2 grams of protein. Next. Socioeconomic history is not contributory. Summary, 6-year-old female child, fourth born to a 3rd-degree consanguineous marriage, belonging to lower socioeconomic status, with a hereditary deficit of 430 kilocalories and dietary deficit of 430 kilocalories and 3.2 grams of protein, immunized appropriately with no developmental delay, with no significant antenatal or birth history, with significant family history of similar complaints in the elder sibling, with history of recurrent upper respiratory tract infection brought with history of chronic progressive ataxia since 2 years of age, which has now aggravated since 15 days. Probable diagnosis on history will be involvement of cerebellum, probably Ataxia-telangiectasia or Friedreich's ataxia, or structural deformities. Next. General physical examination, child is comfortable and cooperative, the vitals being stable. Anthropometry is normal. Head to toe examination, horizontal nystagmus was present in the eyes, Telengiectasia was present with no KF rings, neck was deviated to the left side. Rest of the head to toe examination was normal. In this image, you can see the Telengiectasia in the bulbar side of the conjunctiva, and Gait was wide-based gait with ataxia while walking. Stance was foot being abducted and wide-based gait. Systemic examination, higher mental functions were normal except for the speech, which was slurring of speech was present, able to comprehend the spoken words, reduced tone of voice was present, fluency was affected. Next slide. CNS examination was normal except for the third, fourth, and sixth cranial nerves, where oculomotor apraxia was present. Motor system examination, there was decreased tone in all the four limbs noted, and power and bulk was normal. Next slide. Reflexes were normal except for the knee jerk, which was pendular in nature. Cerebral signs were positive, that is, the titubation was absent, but the nystagmus oculomotor apraxia was present. Incoordination was present in the form of finger nose test and heel to knee test. Dystoidochokinesia was present, fast pointing was present, pendular knee jerk was present, ataxic gait was present, and tandem walking the child was unable to do. Sensory system examination was normal. Other system examination were found to be normal. Diagnosis: 6-year-old girl with chronic progressive hereditary ataxia of cerebral origin with ocular telangiectasia and oculomotor apraxia with recurrent upper respiratory tract infection with similar complaints in the sibling. Diagnosis would be hereditary ataxia, most probably Ataxia-telangiectasia. Investigation.
5 minutes over, ma'am.
I think, yeah, 5 minutes over. I'll take it as he has just presented within 5 minutes. Akshay, good presentation. Go back to your first slide. The HOPI slide. Yeah. This you go next slide. She has come with, this is a 4-year-old child. No, she has come with swaying with initially, starting at 2 years of age. Now, what are the causes for swaying in a child?
Swaying, we can think about any dysfunction wherein there will be causes of ataxia, like any cerebral dysfunction or a vestibular dysfunction or posterior column lesions.
Yeah, okay, good. How do you differentiate a cerebral ataxia from vestibular involvement? Because in both there is unsteadiness of gait in both.
Yes, ma'am. In vestibular involvement, there will be history of associated vertigo or motion sickness will be present. And in case of cerebral involvement, there will be associated truncal ataxia will also be present, wherein difficulty in sitting and squatting will be there, and difficulty in
yes, okay, yeah, I got the answer. Fine. How do you explain the deviation of the neck to one side?
In this case, there can be positional torticollis, wherein due to the swaying, the child may have adopted the position where while walking, the neck might have been tilted to one side, and so.
Any other, you want to link it to, say, cerebral involvement or some structural involvement? One, okay, you're just telling it is postural. But we see many ataxia cases where there is no deviation of neck to one side. Any other explanation? What are the other causes for deviation of neck?
If the child has squint, then for that also.
Yes, fine. Next, anything else? If any intracranial causes which will cause deviation of neck to one side?
Posterior fossa lesions.
Posterior, good, very good. How posterior fossa lesions? See, cerebellum is also there. Yes, which posterior fossa? How posterior fossa lesion will cause deviation of neck?
There can be a mass in the occipital region leading to protuberance of the occiput, which can cause deviation of the neck, like a Dandy Walker malformation. Or
so herniation of the cerebellar tonsils can also cause deviation of neck to one side. Okay, go for the negative histories. You have asked few negative histories. Yes. Yeah, this one. Why did you ask them?
History of spinal deformity is for associated the spinal involvement, like any spina bifida or
no, not spina bifida. If this child has kyphoscoliosis, what you will think of?
That may be a cause for the swaying.
No. Kyphoscoliosis, pes cavus in this child. Familial ataxia. No. Friedreich's ataxia. In Friedreich's ataxia, you get kyphoscoliosis, pes cavus, and all the skeletal deformities. What are the other negative histories you have asked? Why?
History of involuntary movements for nystagmus, and history of abnormality in the eye for if they have any noted any changes in the eye posture positioning of the eye, and dryness of the skin and vision is for autonomic disturbances, and vision problems is to ask for any second cranial involvement. Headache, vomiting, and diplopia for raised intracranial pressure symptoms. Fever,
Diarrhea?
vomiting,
Why did you ask? Diarrhea?
It can be a post-infectious cause of cerebralitis.
Do you think of post-infectious cause? It will go on for 2 years. Now it is progressive. Is it acute or is it chronic?
Chronic progressive.
Chronic progressive. Is post-infectious cause a DD for chronic progressive?
No, acute.
How quickly they will recover in infective causes?
Within 3 to 6 months.
Even before that, no, within 1 month, they can recover. So this is not the diarrhea. Why did you ask for diarrhea? Suppose he has malabsorption.
Malabsorption can be associated with a vitamin E deficiency or B12 deficiency, which can also cause swelling and ataxia.
A beta lipoproteinemia. A beta lipoprotein. Rather than vitamin E, it is A beta lipoprotein. Okay, go for examination. There is recurrent infections in this child. How do you explain that?
There can be associated immunodeficiency. If you are suspecting
what immunodeficiency is common?
The IgA and IgG.
So humoral, A, G, and E. Yes. Fine. CNS examination. Okay. Ataxia, you showed us telengiectasia. No, what are the other sites you will look for telengiectasia?
We should look over the mucous membrane and over the skin.
No, that is very broad. No, the skin means which part? Which part of the body you look for telengiectasia? Apart from eyes.
Over the face and
face again is a broad. Which part of the face? Okay, no problem. Continue. You have written something called oculomotor apraxia here. How did you look for oculomotor apraxia? Can you tell us?
Yes, ma'am. We should initially look for the movements of the eye, that is saccadic and persuade movements, by doing the testing for the extraocular muscles. If there is any fast component is towards the side of the lesion, there will be.
How do you test? What do you understand by the term oculomotor apraxia?
Oculomotor apraxia is difficulty in doing the skilled activities, like difficulty in.
That is apraxia you are telling. I want what is it? How is your apraxia as a part of higher mental function is different from oculomotor apraxia? How did you test them?
By doing finger.
How? Tell me them. How finger? Yes, exactly. How did you do? Finger confrontation means exactly how did you do and what did you find in this patient?
We should sit at the level of the patient. Our eyes should be at the level of the patient at around 1 meter distance, and we should with the patient's eyes. If we are examining the patient's left eye, we have to close our left eye and patient's right.
No, you are telling me confrontation. Here, apraxia heng martira. What is your finding there?
Apraxia, we should look for the movement of the eyeball.
What happens to movement of eyeball?
Decreased in the side of fast component.
No, you are there, but not exactly there. Okay, no problem. Continue. Next slides. Okay, the positive. Yes. Cerebellar signs, you have got cerebellar signs. Okay, what do you mean by pendular knee jerk?
In pendular knee jerk, after we stroke over the tendon, there will be 3 or more oscillations of equal frequency. So it suggests a pendular knee.
Where do you get hung up reflex? You heard of hung up knee jerk?
Yes, ma'am. Hung up reflex.
Where do you get? You heard of this term hung up knee jerk? This is pendular knee jerk, hung up. Where do you get delayed relaxation of knee jerk?
In hypothyroidism.
Hung up knee jerk?
Hypothyroidism.
In Korea you will get hung up knee jerk. Okay. Sydenham's Korea. Yes, go ahead, no problem. Next. Sensory, which sensory system is very important in this child? Select one or two.
Vibration and proprioception.
Why?
Because the posterior column lesions can affect the vibration and the proprioception sensations, which can also present with swaying.
Swaying, yes, good. Yes, next. Go for your diagnosis.
Diagnosis: chronic progressive hereditary ataxia of cerebral origin.
Okay. Now, yes. One
more
minute more.
minutes.
Okay. Yes. 2 more minutes, huh? Yeah, fine.
Yes, ma'am. 2 more minutes.
Now, yes. Now, this child you are telling us Ataxia-telangiectasia. What are the other DDs you want to give in this patient?
We can think of Friedreich's ataxia, spinocerebellar ataxia, or A beta lipoproteinemia.
Okay, no, not all. Okay, how do you differentiate this from spinocerebellar ataxia? What are the points for spinocerebellar ataxia in this child?
There is a chronic and progressive nature of ataxia, and
family history is there.
Family history. Yes.
So there is chronic progressive family history. So what are the points against spinocerebellar ataxia here?
It is usually not associated with recurrent respiratory tract infections, and there is no telengiectasia associated with.
Yes, or a telengiectasia only mild you are getting on the temporal side. So apart from telengiectasia, suppose if it is, what is the strong point in spinocerebellar ataxia?
Other autoimmune diseases.
No. In CNS examination, what is the strong point? Okay, Friedreich's ataxia. What are the findings in Friedreich's ataxia? CNS examination findings.
Yes, in Friedreich's ataxia, there will be extensor plantar with delayed deep tendon reflex will be absent.
Yes, cerebellar signs with upgoing plantar. Upgoing with skeletal involvement. So this is looking more like a Ataxia-telangiectasia. How do you confirm your diagnosis? You've done any? No, I don't want routine, specific investigations.
MRI of the brain has been done, which showed cerebellar atrophy in the vermis.
Again, that is anything else? I want to confirm it as it is telling me some chronic pathology is there in the pericerebellum. This can happen in many conditions, sir.
We can do genetic testing for ATM gene.
Anything else?
And IgA and IgG levels can be tested, which will be decreased in Ataxia-telangiectasia.
How do you treat this child? What is the prognosis?
Treatment is supportive therapy. There is no specific therapy, and a drug which is in trial is riluzole, which is a glutamate antagonist, and prognosis is.
Do you leave him like that? Okay, nothing, no treatment, go home. Will you tell, or what do you monitor in this child?
Rehabilitation should be done by referring
what else? What do you monitor this child for?
We should look for there can be associated with lymphoreticular malignancies like Hodgkin's lymphoma or T-cell leukemias. So we should look for that.
What are the causes of death in Ataxia-telangiectasia?
Cause of death is respiratory.
Pulmonary infections or malignancies. Yes. Okay. Thank you, Akshay.
I'm Harris Richard, a final year medical student from Coimbatore Medical College, and I will now be beginning my case presentation. My patient, Master XYZ, a 4-year-old male child from Coimbatore who was brought to the hospital by his mother, came with the chief complaints of facial puffiness for the past 5 days, abdominal distension for the past 3 days, swelling of both legs for the past 3 days, and reduced urine output for the past 3 days. History of presenting illness: the patient was apparently normal 5 days ago, after which he developed puffiness of the face, which was more around the eyes and insidious in onset, more in the morning upon waking up, and gradually reduces towards the night. It is associated with abdominal distension, which is uniform distension of the entire abdomen, gradually progressive over 3 days to involve the genitals, not associated with any abdominal pain. History of swelling of both the legs is present, insidious in onset and gradually progressive, initially involving the dorsum of the foot and now increasing till the ankle. History of reduced urine output is present. The child passes a small quantity of dark yellow urine once or twice a day. There is no history of difficulty in breathing, cough, or chest pain. No history of jaundice, blood in the vomitus, or black-colored stools. No history of any insect bite or drug intake. No history of recurrent gastroenteritis or reduced food intake. No history of fever, increased frequency, or crying while passing urine. No history of sore throat, skin infections before the onset of disease. There is no history of passing cola-colored urine. No history of headache, blurring of vision, vomiting, or seizures. No history of loose stools or abdominal pain. Past history: there's a similar history in 6 months, similar illness 6 months ago, which was treated with native medications and the symptoms resolved within 10 days. There's no history of exposure to tuberculosis and no other significant past history. There's no history of kidney disorders in the family. Antenatal history: all the trimesters were uneventful. No history of any medical illness in the mother, and no history of any oligohydramnios. Natal and neonatal history was uneventful. 3 kilograms, full-term baby, delivered by normal vaginal delivery. No issues during postpartum period. Child was on exclusive breastfeeds and was discharged on day 3. Diet history has a deficit of 350 kilocalories and a deficit of 4 grams of proteins. Immunization history is immunized up to date as per the national immunization schedule. Last vaccine given was at 18 months, which is DPT, MR, OPV, and vitamin A. The developmental history is normal for age. Summary: a 4-year-old male child with edema that is more in the morning, probably of renal origin, without any history suggestive of cardiac, nutritional, or hepatic cause of the edema, without any history of complications, without any history of suggestive of secondary causes of nephrotic syndrome. This is probably a case of idiopathic nephrotic syndrome. General examination: the child is alert and active, cooperative for examination. Generalized edema is present. Temperature is 98.5 degrees Fahrenheit. Pulse rate is 96 per minute. Regular rhythm, normal volume felt in all peripheral pulses. Respiratory rate is 34 per minute. Capillary filling time is less than 3 seconds. Blood pressure is 84 by 58 millimeters of mercury, measured in the right arm in the sitting posture. Anthropometry is normal. Head to toe examination: frontal bossing is absent. Hair, color, texture, and distribution is normal. Bilateral periorbital puffiness is present. Mild pallor, no icterus, no evidence of vitamin A deficiency. Ear and nose normal, no cyanosis. Dental caries are present in the mouth, no evidence of any micronutrient deficiency. Chest is normal. Abdomen appears uniformly distended. Limbs, there is bilateral pitting fetal edema up to the flanks. No signs of liver cell failure, and scrotal edema is present. Examination of the abdomen: on inspection, it appears uniformly distended. Flanks appear full. All quadrants move equally with respiration. Skin over the abdomen is stretched, not shiny. No scars or sinuses, and no dilated veins. Umbilicus appears flush with skin, appears to be shifted down. Hernial orifices are free, and genitals, there is scrotal edema. On palpation, superficial palpation, the skin is warm, not tender. Inspectory findings are confirmed. Measurements: ziphisternum to umbilicus 21 centimeters, umbilicus to pubic symphysis is 20 centimeters, abdominal girth is 52 centimeters, umbilicus to right anterior left spine is 17 centimeters, umbilicus to left anterior left spine is 16 centimeters. On deep palpation, it is uniformly distended, free fluid is present, liver is palpable 1 centimeter below the right costal margin, no splenomegaly, and no renal angle fullness or tenderness. Percussion: liver span is 7 centimeters, shifting dullness is present. On auscultation, normal bowel sounds are heard, no bruit or venous harm. Other system examination: cardiovascular system, S1, S2 heard, no murmurs. Respiratory system, normal visceral breath sounds heard, no added sounds. Central nervous system, no focal neurological deficit. Provisional diagnosis: this is probably a case of minimal change nephrotic syndrome, second episode of first relapse with no complications. Thank you.
Okay, Harris, that was a very good presentation. Now go for your first slide. Yes. Now, this child has come with facial puffiness, abdominal distension, swelling, and reduced urine output.
Yes.
This child, you think, is having a nephrotic syndrome or a nephritic syndrome?
Ma'am, since there is no history of any hematuria or hypertension.
No, only with this slide you discuss. In this slide, these 4 points, you think this child is having a nephrotic, or more towards nephrotic or more towards nephritis?
It's more towards nephrotic syndrome, ma'am, because of the development of facial puffiness first, and then the sequence of progression of the edema.
Even in nephritic syndrome also, puffiness of face starts first, no?
It is a milder edema compared to nephrotic.
Yes, very good. So here the abdominal distension is more towards nephrotic syndrome. How to explain reduced urine output? Is oliguria a feature of nephritis or nephrotic syndrome?
It is more commonly in, it is a feature of both, but it is present. It is a classical feature of nephritic syndrome. In this case, we have gone with further history. I would first try to rule out other causes of edema, because even left heart failure can cause oliguria. But if we talk about renal causes, I would say it is because of the hypovolemia, and reduced GFR would result in oliguria.
Good. What is the cause for oliguria and nephritic syndrome? Here you said it is because of the reduced intravascular pressure, intravascular volume.
Yes,
in nephritic syndrome?
Maybe due to the deposition of the immune complexes, there is reduced GFR, and that's why there's.
Good. Go for the next slides. Okay. Here nothing. Next slide. Next slide. So these are all okay histories. Next slide. So what are the DDs you have ruled out here?
Ma'am, with my first history of with no history of difficult breathing, cough, or chest pain, I would like to rule out any cardiac causes of edema. With no history of jaundice, hematemesis, or melena, I would like to rule out hepatic causes of edema. With insect bite or drug intake, I'm ruling out any anaphylaxis or allergic causes of edema. With no history of recurrent gastroenteritis, reduced food intake, nutritional causes of edema like kwashiorkor, I'm ruling out. No history of fever or increased frequency of crying, I'm ruling out urinary tract infections, which is one of the causes of renal edema. No history of sore throat or skin infections before the onset of disease, I'm ruling out a post-streptococcal illness.
So, but do you think UTI will present with such severe edema with abdominal distension?
At least not initially, ma'am, in very advanced stages.
No, even in there, it is a very minimal edema. So you don't get an ascites in a pure UTI. But
Okay.
here you are asking because UTI precipitates a nephrotic syndrome.
Nephrotic syndrome.
So it precipitates. So you are mainly asking whether it's a precipitating factor for a relapsed nephrotic syndrome. Yes, next. Next slide. Yes, okay, next. Why did you ask loose stools and abdominal pain again?
Ma'am, in this case, I would like to rule out, it is to rule out complications of nephrotic syndrome, spontaneous bacterial peritonitis. They may present with loose stools or abdominal pain. So to rule out that.
Yes, what is the likely organism there?
Streptococcal pneumonia is most common.
Pneumonia. So in your immunization history, you didn't tell us about the optional vaccines. Go to your immunization history.
Yes, ma'am.
So of course, now in the national schedule, off late pneumococcal vaccine is there. Because as an older child, you should ask about specifically write about pneumococcal vaccine. Yes, next. Your impression at the end of history?
Ma'am, I've ruled out all other causes of edema other than renal edema. So I would, the edema is due to renal origin, and there are no complications involved, and there are no secondary, any history suggests of secondary causes.
What are the secondary causes of nephrotic syndrome?
Ma'am, there may be drugs such as penicillamine, NSAIDs, lithium, heroin, etc.
Which is more common, primary or secondary?
Primary. Idiopathic is more common. 90% of the cases are idiopathic.
Okay, okay, yes. Next slide. Okay, okay, next. Now, another important point here is blood pressure you have written is 84/58. What is it? What is that? What is your interpretation of the blood pressure in this child?
It appears normal, no?
It appears normal is different. It is normal is different. So what, if given another opportunity, how you would have interpreted that blood pressure? What is the definition of hypertension? When do you say hypertension in a child? What should be the blood pressure?
Greater than 100.
So it is more than 95th centile. So you have to carry the percentile charts in the exam.
Okay.
Whenever you are presenting a renal case, and you should tell it is less than 95th centile. Then that that tells that there is no hypertension. Okay. Otherwise, it is difficult to tell because in an younger child, blood pressure will be lower. Still, this may be hypertension like that. Okay. So carry percentile charts in exam. Now, why? Suppose if it is a nephrotic syndrome and he has hypertension, what is your interpretation? Is hypertension feature of nephrotic syndrome?
It is more commonly a feature of nephritic syndrome.
Yes. Now it is nephrotic with hypertension. What do you suspect?
I wouldn't suspect a minimal change disease. It would be a significant lesion in that case.
Very good. So you think of a significant lesion. Now, what percentage of minimal change nephrotic syndrome can still have hypertension? You said what you said is perfectly fine. Hypertension, hematuria is more a feature of significant lesion. But certain small percentage of minimal change nephrotic syndrome can still have hypertension. Do you know that?
I'm not aware of.
No, it's okay. No problem. That's a PG question. Yes, continue. Next, continue. Okay. Yes. Apart from ascites and scrotal edema, you have not got any positive finding in head-to-toe exam. Yes, next. Per abdomen examination. Again, you have had. So how do you look for free? What are the tests you will do for free fluid in abdomen?
Shifting dullness, ma'am, and puddle sign, fluid thrill, ma'am.
So what in that order? In what order?
If there is more than 1.5 liters of fluid, we can elicit shifting dullness. If there's lesser than that, we can try to elicit puddle sign by putting the patient knee elbow position and auscultating.
What is the minimal amount of fluid you can pick up by puddle sign?
100 ml of
150 to 300 ml. Yes. You didn't tell us about, did you tell us about shifting dullness? Next slide.
this one.
Free fluid present you have written. Yes, by what you have written here. Yes. Percussion shifting. Now your liver span is 7 centimeters. Is it normal? Child's age is 4 years, you said. What is the age of the child? 4 years.
4 years old.
So is 7 centimeters normal for a 4-year-old child?
Yes, ma'am.
What is the liver span in a newborn?
I'm not aware of.
Okay, no problem. It is normal. What you said is right. Now, what do you expect hepatomegaly in nephrotic syndrome, or you don't expect?
Ma'am, in nephrotic syndrome, maybe before the liver has to work overtime to compensate for the.
Yes, exactly. You will get hepatomegaly, but somehow your child here is not having hepatomegaly. Yes, next slide. Yes, next. So your diagnosis is minimal change nephrotic syndrome, first relapse. What precipitates a relapse in nephrotic syndrome?
Any infection about urinary tract.
Which infections? Which infection?
Urinary tract infection, respiratory tract.
Apart from that, respiratory tract. How do you prevent relapses in nephrotic syndrome?
Vaccination. Okay, we counsel the parents.
What vaccinations? What vaccinations?
Pneumococcal vaccines, varicella vaccination.
And the recent guidelines say you'll have to give influenza immunization also in them, so that it prevents a relapse. Do you know any other way we can prevent a relapse in nephrotic syndrome? Recently, we are doing a different management for nephrotic syndrome to prevent a relapse. Whenever they have a infection, viral infection, we'll give a short course of steroids for about 7 days.
Okay.
Even though they don't have a relapse, so that they don't get a relapse with that infection, 5 to 7 days. So this is in the recent guidelines. So that prevents a relapse in these children. Okay, fine. Can you tell me what is frequently relapsing nephrotic syndrome?
Greater than 2 episodes per 6 months, or greater than 4 episodes per in 1 year is known as frequently relapsing nephrotic syndrome.
Okay. Yes, that is little bit changed in the recent guidelines. What you said is that there is one more thing. The recent guidelines are released from IAP, but I will give it for you. No, this is there in your OP guide. Yes, next slide.
Last 1 minute, ma'am.
Yes, last 1 minute. Give me specific investigations you will do in this child to prove your diagnosis.
To start with, urine can be analyzed for protein, ma'am.
What will it be?
Dipstick test will be greater than 3+ or 4+ in this case.
Yes, one more investigation.
Protein creatinine ratio will be greater than 0.2.
Greater than 0.2 or greater than 2?
Greater than 2, ma'am.
2. Next, something else in investigation?
We might also find pus cells or RBC casts can be present in case if we have to look for them in the.
No, first confirm your diagnosis. What else you will do to confirm the diagnosis of nephrotic syndrome? What are the 4 components of nephrotic syndrome?
Massive proteinuria, generalized edema, hypoalbuminemia, and hypercholesterol.
So you prove that first. Okay. Hypercholesterol. What should be the total cholesterol?
Greater than 200 milligrams per deciliter.
Yes. What should be the serum albumin?
Lesser than 2.5 milligrams per deciliter. Grams per deciliter.
Okay. Yes. Next, how do you treat this relapse? Now it is a frequently relapsing or infrequently relapsing nephrotic syndrome? This is just the first relapse.
It's only the first relapse.
First relapse. Okay. Yes. Next. How do you treat this first relapse?
Ma'am, I would like to start him on a course of steroids, ma'am. Prednisolone, 2 milligrams per kg per hour for 6 weeks, 2 to 3 divided doses, followed by 1.5 milligrams for 6 weeks. Every one single dose.
That is the first episode you are telling. Now he is relapsed.
We can also start with other drugs like cyclophosphamide, lerimazole.
No. why you want to start is you only are telling this is just the first relapse, madam. First relapse, you want to start cyclophosphamide. In this patient, how do you treat? You tell me. That will be my last question.
Diet restriction can be done, ma'am. Salt, no added salt. We can counsel the patient.
Okay, specific treatment. Specific treatment. How long you give steroids? You said 2 mg per kg per day. How long? In a relapse? No. Till they go into remission. Because it is relapse. Till they go into remission. Then immediately shift to 1.5 mg per kg per day. And that you will give for 4 weeks. 6 plus 6 is for first episode. Okay? Okay. Thank you, Harris.
2 days old male baby born to Mrs. ABC. Mother age is 28 years. She is educated till BCom, religion by Hindu. Socioeconomic status upper middle class, informant, mother unreliable, admitted for postnatal care. Antenatal history, second order born to non-consanguineous mother to a G2, P2, L2, A0 lady at 38 weeks by LSCS. From first trimester, she's a book test, spontaneous pregnancy diagnosed by UPT after 5 weeks of amenorrhea, confirmed by ultrasound, followed by a dating scan at 8 weeks. Preconceptional folic acid was not taken, but once pregnancy was confirmed, it was started. All mandatory tests were done and was found to be within normal limit. Mother blood group was O negative and father blood group was A positive. There was no history with fever with rash. Second trimester, NTA-NP scan was done at 12 weeks. Well marker test was not done. Iron, folic and calcium tablet were taken. There was a history of increased vomiting at 16th week for which medication was taken and it subsided in few days. Anomaly scan was done at 20 weeks and was found to be normal. Serial RH isotiter was done and found to be within normal limits at 16 and 24 weeks. Fetal movement first perceived at 17th week. There was no history of fever with rash, no history of increased urination, no history of bleeding or leaking PU. Third trimester history, growth scan was done at 28 week and was found to be normal. NTD injection was given at 28 and 34 week. OGTT test was done and was found to be within normal limits. Adequate fetal movement perceived. There was no leakage risk. Internatal history, mother got herself admitted at 38 weeks with onset of labor pain, after which tolic was done and due to inadequate progress of labor, which was proceeded with LSCS. Baby was born at 12:30 am on 25th November 21. Cried at birth. Birth weight of baby was 3.7 kg. Baby was handed over to mother only after 2.5 hours and was unable to express milk. Hence, baby was artificially fed, and and baby can only be breastfed later at night. Mother was given NTD injection after delivery. Immediate postnatal. Baby passed stool and urine within 24 hours. There was no history of fever, no history of abnormal movement, no history of ULH discretion in first 24 hours. Breastfeeding. First night baby was breastfed for 6 to 7 times. In day 5 to 6 times, and average duration of 5 to 10 minutes. I have observed a breastfeeding session after obtaining a due consent. Mother held the baby in sitting position with baby well supported. Baby was able to attach properly to breast. Baby couldn't suck for more than 3 to 4 minutes and went to sleep after session. Baby used to awake with crying every 30 to 45 minutes, which was followed by another breastfeeding session. Family history, first sibling was male, 2 years, 4 months, born at 39 weeks through meconium state lighter and was delivered by LSCS and is now healthy and fully immunized as per UIP. There was no history of TB in family. Now I'll proceed with examination. Baby was examined on bed and on mother's lap. Baby's vital load pulse rate 132 per minute, capillary fill time 1.5 seconds, respiratory rate 53 per minute, temperature 98.8 degree Fahrenheit, no cyanosis, no pallor, no ectasis, no lymphadenopathy or no clubbing. Anthropometry, head circumference was 35 centimeter, anterior fontanelle measures 2 into 1.8 centimeter, baby weight was 2.940 kg, length 49 centimeter, chest circumference 36 centimeter. From head to toe examination was normal essentially, except the skin yellowish discoloration was plus minus. From systemic examination, higher mental function, baby reacts to stimuli, consolability was present, baby shifts in various states of alertness and habituation was present. Motor examination, passive tone, popliteal angle less than 90 degree, erector angle less than 90 degree, scarf sign, elbow doesn't cross midline, heel to air not complete. Active tone, pull to sit, head, there was head lag, non-dorsal suspension, head was not in the plane and arm recoil test was positive. So reflex, rooting reflex was present, sucking reflex present, palmar grasp present, morose reflex complete with all component and ATNR present. Other system examination were essentially normal. Diagnosis, as single term male, 2 days old, delivered at 38 weeks of period of gestation by LSCS to a non-RH allo-immunized mother with birth weight of 3.7 kg found to have excessive weight loss postnatally and has poor breastfeeding habit. And follow-up, I could see there was later on the day of examination, baby developed village discoloration of palm and soles and was admitted to NICU for the same. His bilirubin test was done, which was found to be 70 milligram per DL. Baby was discharged from NICU on Monday, 29/11/21, that is, and baby is breastfeeding adequately now and currently receiving phototherapy, and the baby will be discharged soon.
Okay. Anuj, that was a good presentation. You go back to your slide, first slide. Yeah, he is a 2-day-old male baby. You should, yes, you have examined on the second day.
Yes.
How many hours of life you should write? See, it's very important here that you have noticed jaundice. Mother has not told jaundice. So here the day of examination is important. Is it 48? I mean, hours of examination is important. Is it 36 hours, 48 hours? So like that you should write. One. Yes, continue. Next slide. Next slide. Next slide. Okay. Yeah. Before slide.
Ma'am, mother, this is RH.
Why? Now, yeah, I know. Now, why you want preconceptional folic acid was not taken, you have written. So, why do you give folic acid and what is the dose?
Ma'am, folic acid is available in India as 500 microgram dose, and it is started preconceptionally. It helps in prevention of neural tube defects by 80%.
So, what is the dose of folic acid in prevention of neural tube defects, and what is the dose normally given in any mother during pregnancy?
Ma'am, for prevention, it is 4 milligram, and for it normally it is 1 milligram.
No, you cross check. You cross check. This is a common question we ask. Now this mother is O negative mother, and she has already delivered a baby. So you need to be, suppose if you are a treating obstetrician, how you will monitor for RH incompatibility? Has she received anti-D in her first pregnancy?
Yes, ma'am.
That is not mentioned here. Have you mentioned?
No, ma'am, I didn't mention. I mentioned for this pregnancy.
Yeah, previous pregnancy is it in this pregnancy is for the next child. I'm bothered about whether she has received in the previous pregnancy.
Yeah, yes, ma'am.
So that should be written in the case sheet. That should be documented in the case sheet. Yes. Now next slide. Suppose if there is both father is A positive, mother is O negative. Suppose there is there is both RH and ABO incompatibility. Is a child going to have more severe hyperbilirubinemia or less severe jaundice?
Less severe.
Why? There is both RH and ABO incompatibility.
Because if ABO incompatibility is there, if the fetal blood enters in mother circulation, it will be immediately destroyed. But if it is RH incompatible, then it can generate an immune reaction later.
Yes. Yes. Good. Yes. Next. Yes. Otherwise, and perinatal period was antenatal period was normal. Next slide. See, baby born and cried at birth. If possible, you should write Apgar score. Otherwise, in the exam, it is okay. So, Apgar score below how much is suggestive of birth asphyxia?
Below 3.
Is severe birth asphyxia. That means is 4 and 5 normal?
No, 4 and 5 is not normal. Below
how much is, or rather, how much more than how much is normal?
More than 7 is normal.
So you should, if it is known, you should write there. Now you have written baby was handed over to mother only after 2.5 hours. Now, ideally, when if there is no problem, baby has cried immediately after birth, then ideally breastfeeding should be started.
Immediately it should be started because it will help in prevention of PPH and better mother to child bonding.
What do you mean by immediate? It is as soon as possible. Accept that answer. But
on the delivery table.
On the delivery table is fine, correct. Suppose for some reason I am not able to initiate breastfeeding, within what time? What is the guideline given?
Within 30 minutes. Within 30 minutes.
Within 1 hour. According to IYCF, it is within 1 hour of delivery. But as you said, I will accept that answer. On the delivery table only, you should breastfeed the baby. Yes, next slide. Yes, give me some causes for delayed passage of stools beyond 24 hours.
Ma'am, it can be a meconium plug that can be there, or it can be duodenal atresia and Hirschsprung disease.
Yes, some surgical cause important, some medical cause important. You are telling me all surgical causes. Important medical cause.
Ma'am, paralytic ileus.
Medical cause. Paralytic ileus can be medical, but important. Treatable MR.
Necrotizing
endocrine cause.
Ma'am, hypothyroidism.
Hypothyroidism, you should keep in mind. You have written no history of yellowish discoloration in first 24 hours. I'll give you marks for that. Now, why? What is the importance? Why you have written that statement?
Ma'am, that is a cause of pathological jaundice. We should in first 24 hours.
What are the causes for pathological jaundice within first 24 hours of life?
Ma'am, it could be due to RH incompatibility in this case, in first 20, or it can be any concealed hemorrhage somewhere, or it could be due to any sepsis, or any obstructive cause of obstructive jaundice.
ABO. All they will present later. Very important is RH and ABO.
ABO incompatibility.
Now you have written something about breastfeeding. He was fed 6 to 7 times and all that. Ideally, how many times a mother should breastfeed a baby?
Ideally, breastfeeding should be done on demand, and at daytime or 2 hourly. It should be done 2 hourly, and at least 2 night feeds should be done.
Minimum how many feeds overall?
The minimum 8 feeds.
Yes, very good. Minimum. How do you check adequacy of breastfeeding? Here you are telling something that inadequate breastfeeding and all that.
Ma'am, adequate breastfeeding is after baby has fed properly, he will sleep comfortably for at least 1 to 2 hours. Then and also there will be adequate weight gain. If you will check for serial weight gain, there will be adequate weight gain.
That weight gain is later. Now, history wise, as of now, if I want to confirm, one is what did you tell first point? He's sleeping. Next, another point. You missed another point.
Ma'am, should pass urine out. Urine out.
How many times? How many times he should pass an adequately breastfed baby?
Ma'am, 4 to 6 times.
6 times. More than 6 times in a day. So that you have not documented. Show me the next slide. You have not documented the sleeping and this one. Huh?
Yes.
So that is important. And urine output. What should be the adequate weight gain of an exclusively breastfed, adequately breastfed baby?
Ma'am, 30 to 40 grams per day.
Yes. Okay. Now you have said mother is feeding the baby in sitting position, well supported. What are the? Tell me 4 points for good positioning of the child.
Ma'am, baby should be held on the mother arm, and baby should be turned towards the breast, not the other way. And the baby should attach good attachments. Baby should attach.
Attachment is different. Positioning is different. I'm asking for positioning now.
Ma'am, baby should be well supported. Should be turned towards the breast, and should be skin to skin contact should be there.
4 points.
And neck should be supported.
Entire body should be supported.
Neck
Yes.
and body.
Okay. Yes. Next slide. Okay. Next. What is that CRT 1.5 second? See, 1 second only. I understood. See, to look at 1 second only is difficult. How did you make out half second in that? So you should not write 1.5, 1.2 second like that. It is less than 2 seconds. Like that you should write. Don't write 1.5 like that. Okay. Now respiratory rate is 53. Is it okay? Normal, abnormal?
Yes, ma'am, it is normal for a newborn.
When do you say tachypnea?
Ma'am, more than 60.
Here you have written no icterus, and next slide you have written icterus is present.
No, it's plus minus in skin. I tried to visualize in daylight, but it was plus minus. I could not comment.
In the exam, you should be sure. You cannot tell whether you should be confident. Tell it is there or not there. So show me your next slide. Something you said about icterus, no?
Yes.
You said icterus is there or something you said. Where is that point? Yellowish discoloration plus minus you should not write in exam. You should be confident of your finding. It's there or not. What is Kramer's criteria?
Ma'am, Kramer has divided the zone into 5 zones. Head, upper body, lower abdomen, and limb 4 and soul is 5. Soul and
yes.
palm.
When you cannot apply Kramer's criteria. Certain situations you cannot apply Kramer's criteria. If the baby is on phototherapy.
Phototherapy.
Second, if it is a preterm child. Preterm child. Yes. Next slide. Yes, you should write your impressions. How did you look for popliteal angle and adductor angle? I appreciate you have done, but how do you do that?
Ma'am, by folding the baby legs towards the abdomen, and then we'll check what is the angle between the knee and the.
Yes, you should write the whether it is normal or not. Interpretation.
Ma'am, it is normal
yes,
for a term baby. Normal
so have you assessed his gestational age?
Yes, ma'am.
Where is the
gestational age I have not assessed with Ballard score. Should you do that?
You should assess.
Yeah, you should do it in every case, but she is already a booked case and she's all gone in every investigation.
No. How do you say she is proved case?
Booked case, ma'am.
Booked case is okay. See, mother will tell my gestational period is this much. Her LMP may be different, no? So you have to cross check. She will not be having records. You have to do in all cases. You should do Ballard scoring. So up to what age you will do Ballard scoring?
Ma'am, up till 28 days.
No, not up to. Usually up to 72 hours you can do, up to 3 days of age. Your OP guy has given till 1 week. So, but beyond 1 week of age you cannot do. Okay. Yes. Next.
Last 30 seconds, ma'am.
Okay, fine. Next slide. What's your diagnosis?
Ma'am, found to have excessive weight loss postnatally and poor breastfeeding habit.
See, he is a term. Diagnosis should be term male. He is AGA, LGA, or SGA. What is AGA?
Age appropriate for gestation.
How do you say that?
If our EDD matches with
No. That is term. Age again should look at the charts. Growth charts. Anything between 10th and 90th centile is appropriate for gestational age. So you should carry both charts in exam. Ballard's scoring chart and growth charts. So growth chart should be carried and plotted in the exam. So is found to have excessive weight loss and poor breastfeeding habit. You think this jaundice he has developed, next slides, he has developed jaundice later, no? So you think this jaundice is due to RH incompatibility or is due to, how do you confirm?
Ma'am, since the RH isotiter were not raised during antenatal period and she had received all the doses of anti-D, I will not.
But still, can you get?
No,
So how do you say that it is not? How do you say that? Now, being a pediatrician, suppose say you are treating pediatrician. How to say that this is not due to RH incompatibility?
I will do a Coombs test.
Direct Coombs test. You can do a DCT. What are the baby is discharged? What are the danger signs you will tell on discharge? You can answer that, and that will be my last question.
Ma'am, signs of danger signs of jaundice, all yellowish discoloration of palm and stones, and if baby is lethargic, feeding poorly, or he develops any convulsion or and passage of excessive stools.
Okay, fine. Thank you.
Thank you, Mr. Anishko.
Final year MBBS student from Medical College, Kolkata. And I am going to present a case of a 9-year-old boy child whose name is ABC, who is from Howrah and is a Muslim by religion. He was admitted on 8th of August and was examined by me on 9th of August. His informant was his grandmother, who appears to be reliable. His chief complaints were bleeding spots all over the body spontaneously or after trivial injury since his age of 2 years. And he has been having headache for the last 3 days. History of presenting illness. Patient was apparently well till 2 years of age when his caregivers noticed small reddish blue bleeding spots all over his body. They appeared spontaneously or after trivial trauma, sudden in onset, and were of size 1 to 2 centimeters. When occurring spontaneously, the child suffered from mild cough and cold 3 to 4 days before. There is history of gum bleeding, nose bleeding, blood in stool, and urine. The patient got admitted due to having severe headache in the front and back of the head for 3 days before admission. There is no history of any swelling or glandular enlargement, fatigue, joint swelling or joint pain, colicky abdominal pain, skin rash, fever, yellowish discoloration of eyes and urine, or any focal neurological deficits. Normal bowel, bladder habits, sleep, and appetite. Patient on mixed diet. History of past illness. Patient has a past episode of unconsciousness and coma due to intracerebral hemorrhage. It was mentioned in records when he was of age 3 years, for which he was admitted and recovered eventually. There is no other history of any significant medical or surgical illness. Family history. There is no similar complaints any of the family members born out of a non-consanguineous marriage. All family members are healthy and free from any chronic disease. This is his pedigree chart. Birth history, antenatal history, it was a booked case. Regular ANC was done. IFA tablet and TD vaccines were taken. It was uneventful. Natal history, normal vaginal delivery, institutional birth, term baby, 2.8 kg birth weight, uneventful. Baby cried just after birth. Postnatal history, discharge after 3 days, uneventful. Nutritional history, early initiation of breastfeeding done. Child got exclusively breastfed up to 7 months and was started on complementary feeding thereafter. Now the child takes a mixed diet with adequate calorie and protein consumption. Immunization history was up to date according to MCP card. No other vaccines from outside taken. Developmental history, gross motor, fine motor, language, and socio-adaptive milestones achieved as per age. Socioeconomic history, they lived in a Pakka house having 2 rooms with 4 members, that is overcrowding absent, sanitation adequate with source of clean drinking water, lower middle class. General survey, patient is alert, conscious, cooperative, well-oriented to time, place, person. Nutrition was average, build was also average. Now coming to the head-to-toe examination, I noticed small petechiae of size 1 to 2 centimeters scattered all over the body, over skin and mucous membranes, involving face, trunk, and extremities. There are signs of healed bleeding spots over skin and over gums. Faces were not remarkable, decubitus of choice, pallor cyanosis, clubbing edema absent, neck veins not engorged, neck nodes not palpable. The vitals were all within normal limits. Anthropometry was also within normal limits. Systemic examination, hematopoietic system, lymph nodes were not enlarged palpable in any of the regions. There was no hepatosplenomegaly. There was no bony tenderness. Other systemic examinations were also within normal limits. Summary, so a 9-year-old boy, ABC, was admitted with history of bleeding spots all over the body spontaneously or after trivial injury since age of 2 years and headache for last 3 days. The spots were sudden in onset and were of size 1 to 2 centimeters. When occurring spontaneously, the child suffered from mild cough and cold 3 to 4 days before. There is history of gum bleeding, nose bleeding, blood in stool, and urine. Patient had a past history of unconsciousness and coma due to intracerebral hemorrhage when he was of age 3 years. On examination, small petechiae of size 1 to 2 centimeters scattered all over the body, over skin and mucous membranes. There are signs of healed bleeding spots. There was no lymph node enlargement or hepatosplenomegaly. So my provisional diagnosis is, this is a case of purpura, most probably immune thrombocytopenia in a 9-year-old child currently not having any complications. Thank you.
Okay. Ritudeep, good presentation. Go back to your first slide. Go back to your first slide. Yes. First slide means presenting complaints. So, if you get a 9-year-old child with this complaint, what do you think?
I will think of first of all bleeding abnormality. So this child has bleeding abnormality that the parent only says. So there can be types of bleeding abnormalities like platelet abnormality, vascular abnormality, and coagulation factor abnormality.
Yes, good. So you think of a coagulation abnormality or a platelet abnormality in this child? Platelet and vascular.
Ma'am, from the history of presenting illness, he says that that he was having nose bleeding, gum bleeding, and hematuria, and also in stools. So it is a sign of purpuric platelet abnormality, not coagulation abnormality.
So how does a coagulation abnormality present?
Ma'am, it primarily presents as joint swelling, hematuria, in muscle bleeding.
So in platelet and vascular bleeding, what cause you are thinking in this particular child?
Ma'am, as because the most common cause in childhood is ITP, so I am thinking of secondary causes.
Yes, what are the other causes? Yes,
like SLE, HIV infection, leukemia, lymphoma. These are the causes of, and drugs.
Yes. So for one thrombocytopenia, without, suppose you do a platelet count in this child and it is normal. What are the other causes for this presentation?
Yes, ma'am. We can think of platelet function disorders.
Good. Can you name some platelet function thrombocythemias?
Ma'am, Blansman's thrombosthenia, Browner-Solier syndrome.
Yes, good. So suppose there is no platelet function abnormality, platelet abnormality. Platelet count is normal. Function is also normal. What do you think?
We can think of vascular abnormalities like itis, HSP, henoxolin purpura, or scurvy. This vascular.
Okay, good. Go for the next slide. Okay. What do you think is the cause for his headache and the past history of one intracranial event and all this?
CNS bleeding is very rare if we provisionally diagnose as ITP. CNS bleeding is very rare, less than 1% of cases.
What should be the platelet count to have a CNS bleed?
Ma'am, it should be definitely less than 10,000.
10,000, yes, good. So what are the points in the history that is ruling out a malignancy in the history?
Ma'am, he is not having any significant weight loss. He is not having that is neck swelling or any other inguinal lymph node swelling. There is no fat and there is no fever.
Yes.
So
okay.
Ruled out.
Okay. Yes. Can you tell me some drugs which will cause thrombocytopenia?
Ma'am, the anticonvulsants may cause anticonvulsant like phenytoin, valproate, carbamazepine. Then
fine. Okay, no problem. Next slide. Yes, there is a big list. No problem. Yes, next slide. Yes. What should we now? He's having all this problem from past. He's 9 years old, means from 6 years. What should be the duration of thrombocytopenia to say chronic thrombocytopenia?
EPIGNOSIS says it is more than 6 years.
There is a some books say more than 6 months.
6 months.
More than 6 months. Some books say 1 year.
That's why
more than 1 year. Yes. Next. Next. Okay. Yes. Next. Can you tell me some condition where there is both coagulation abnormality and platelet abnormality?
Both coagulation, DIC.
DIC. Good. Good. Well-looking child. Very good. Sick-looking child, DIC. Well-looking child, He is having coagulation abnormality with thrombocytopenia.
Thrombocytopenia, coagulation.
Which type of von Willebrand's disease can
Yes,
have?
von Willebrand disease.
Type 2B can also have thrombocytopenia.
Type 2,
Yes, continue. Next. Go for examination.
Yes, ma'am.
So he is having, how do you differentiate between petechiae and purpura?
Petechiae are of size 1 to 2 centimeters and a little larger. And purpura are generally in the lower extremities, and petechiae may be in all over the body.
How do you differentiate petechiae from mosquito bite? You are having all.
Yes, ma'am. Mosquito bite, there will be redness, then there will be a
Your petechiae also is red, no?
edema over there.
All will not have edema.
Ma'am, there is no blanching in mosquito bite.
No, in petechiae there is no blanching.
Yes,
in petechiae
mosquito bite
you don't have blanching. Okay. Yes. Next, continue. Next slide. Okay. Anthropometry, you have to interpret using growth charts. Yes. Next. So, why you have put all this, no hepatosplenomegaly and all these things? Can you explain your findings?
Splenomegaly, if present, may indicate towards leukemia.
Where did you look for bony tenderness?
Sternal and chest.
Sternal and
sorry.
I didn't hear you.
Sorry, ma'am. Ma'am, sternal tenderness and on the anterior surface of tibia.
Okay. Yes. Okay. Yes. How? Okay. Next slide. Okay. Yes. So, what is your impression?
Ma'am, most probably immune thrombocytopenia.
Immune thrombocytopenia. Yes. Next. How do you approach this case? What investigations you have done in this case?
Ma'am, I will give him a complete blood count. Which
is this the age group for ITP?
Oh, ma'am, ITP age group is 2 to 5 years. He was diagnosed.
Yes.
2 years.
He was
diagnosed in 3 years. Diagnosed in 3 years. And
can you tell me the age in ITP? Suppose you have an older child, say 9 years, he was diagnosed now with ITP, and a 2-year-old child, he is diagnosed now with ITP. Between these two children, one 2-year and one 9-year-old, who has a good prognosis?
Ma'am, acute ITP has a good prognosis. Those have been recently
diagnosed. 9-year also is acute ITP. Recently diagnosed.
Or recently diagnosed. No, ma'am. 2-year-old child has good prognosis.
In what sense?
Ma'am, we can wait and watch the 2-year child. But
what percentage of your acute ITP is going to become chronic?
Ma'am, 2%.
20%. 20% will become going to develop chronic, but in older children after 5 years, 50% will become chronic. So the chance of chronicity is more as the age advances. Okay. Yes. Next, investigations.
Ma'am, I will do a platelet count and
show me your investigations. You have not made slide.
I have not written.
Okay. Specific investigations.
What sir said that I have to write to only.
No problem. Tell me your investigations.
Ma'am, I will do a complete blood count. So it will entail a platelet count also, and be decreased. And then I may or may not do a bone marrow examination to confirm my diagnosis.
What in the investigation will prompt you towards a bone marrow examination? What in CBC will prompt you towards a bone marrow examination?
Ma'am, there can be in the WBC count, there may be increased WBC, so it may point towards leukemia, or there may be blasts or in the peripheral blood smear. So it will prompt me for a bone marrow examination.
Or a disproportionate anemia.
Yes, ma'am.
Disproportionate anemia or any bicytopenia.
Yes,
Leukopenia or leukocytosis or disproportionate anemia should prompt. Suppose you have done a bone marrow. So what is the bone marrow finding, aspiration finding in a ITP?
Ma'am, normal or decreased number of megakaryocytes will be found.
Increased, normal or increased or decreased? What you are telling? Increased or decreased megakaryocytes?
Increased.
Increased, because marrow is normal or abnormal in ITP? It is normal. So
Normal,
you will get more megakaryocytes. So because this is chronic ITP, any specific investigation you want to do?
To rule out the secondary causes, I can do
What?
HIV.
Yes. Next.
SLE.
For SLE, what investigation you want to do?
Anti-nuclear antibody.
Yeah, ANA profile and HIV you want to do. Okay, how do you treat this child?
Ma'am, childhood ITP is mostly treated by wait and watch therapy, observation therapy. But if we want, we can give.
This particular child,
yes,
child who is having mucous membrane bleeding through GIT, this child, how you will manage?
Ma'am, we can give him intravenous immunoglobulin. We can give him anti-D immunoglobulin, oral corticosteroids. Then,
you think he will respond to these three?
No, ma'am. He is having severe bleeding, so we may have to give him platelet transfusions, or in severe cases, splenectomy. You have to.
Severe cases, what?
Splenectomy.
Okay. Fine. Any other? 15 seconds, over. Dr. Meghana, time is up.
Yes, ma'am. 15 minutes over, ma'am.
Okay.
If anything is there, you can ask me.
Okay. What is the most recent treatment that is being given? It is available in India. We are also giving everywhere. Can you just tell me one and you can go? Ritudip?
Ma'am, any drug, monoclonal antibody?
Monoclonal antibody, rituximab you can give. Any other?
Plasmapheresis.
No. Thrombopoietin receptor.
Yes, L-Thrombopag.
L-Thrombopag.
Another is with
Romiplastin.
Romiplastin.
Okay, yes, thank you, Ritudip. Thank you.
A case of a male patient by the name XYZ, whose age is 1 year 8 months and the date of birth is 13th March 2020.
We are not.
He's hailing from Kumar.
Nisarga, please make it slideshow.
Yes, ma'am.
Make it slideshow. We are not seeing the slides.
Oh, not
The down one.
Ma'am, now?
Yeah, now make it slideshow.
Ma'am, I put it in slideshow.
It's okay, no problem. You have not put it in slideshow, no problem. Continue.
The mother came with the child presenting with features of cough since 1 week, hurried breathing since 2 days, and chest and drawing since 2 days. History of presenting illness. Child was apparently normal 1 week back.
Your
and then
slides
he
are
developed
not moving. Nisarga, your slides are not moving.
From beginning.
Now it is moving.
Yes, tell me.
History of presenting illness. Child was apparently normal 1 week back, and then he developed cough, which was progressive. Initially, it was dry cough with 10 to 12 bouts per day, no aggravating relieving factors, no diurnal variation, no postural variation, and child was alert and playful. Cough increased in severity with 14 to 15 bouts per day. Child was alert and playful. 2 days prior to the hospital visit, child had 24 to 26 bouts of cough per day, which was
we are not seeing the slides. Nisarga, I think you have to make it slideshow.
Ma'am, I pressed slideshow.
In slideshow, go to, from beginning slide, you go there.
Yeah. Now? Is it fine now, ma'am?
No, from current slide you make, we will see. No.
Is it, now is it,
now it is, we are seeing, but the thing is next slide, will move the next slide.
Ma'am, now?
No, we are not seeing.
Ma'am, now can you see?
No, if you move to the next slide, we will not be seeing. Next slide.
Select the slide from the slide panel, Nisarga. The beside one.
You click from
You can
the slide
select
panel.
the slide. Yeah, there you select the slide, whichever you want.
Yeah.
Okay, is it fine now?
Yeah. Yeah.
Okay. 2 days prior to the hospital visit, child had 24 to 26 bouts of cough per day, and it was associated with hurried breathing, noisy breathing, chest indrawing, sleep disturbances, and reduced activity. There's no history of vomiting after bouts of cough, no history of fever, rashes, no history of running nose or difficulty in swallowing, no history of regurgitation of feeds, vomiting, no history of bluish discoloration of the lips and extremities, no history of refusal of feeds, episodes of unconsciousness, convulsions, altered sensorium, no history of wheeze, no history of bottle feeding, no history of similar complaints in the family. Past history. Child was admitted at the age of 3 months at Apollo Hospital for 13 days and was diagnosed with pneumonia. Child recovered completely and was discharged. Child was admitted again at the age of 8 months in a private hospital for 10 days, diagnosed with pneumonia. Child recovered and was discharged. Child was admitted 5 months back at our hospital for complaints of cough, hurried breathing, and chest indrawing. Child's condition did not improve on antibiotic treatment, which was given for 10 days. So further investigations were done, and the 2D echo did not reveal any congenital heart disease. HRCT revealed lymphadenopathy, and the CB-NAT was negative. But on radiological suspicion, child was started on anti-tubercular treatment. Child's condition improved after 5 days, and child was discharged. There's no history of foreign body inhalation, no history of skin infections, no history of ear infection. Antenatal history, uneventful. Natal history, full-term, elective, lower segment cesarean section was conducted at private hospital. The baby cried immediately and the birth weight was 2,800 grams. No prelacteal feeds were given. Breastfeeding was initiated within 1 hour of life. No history of NICU admission. Development to appropriate for age. Child was immunized up to date. Diet history, child was exclusively breastfed for 6 months and the breastfeeding was done up to 8 months. So the expected calories was 1,150 kilocalories, but the observed is 750 and there's a deficit of 34%. Expected protein should be 22 grams, but it was observed to be only 18 grams, deficit 18%. Family history, it's a first order child, 3rd degree consanguineous marriage. There's no history of asthma, no history of similar complaints in the family, no history of blood transfusion in parents. Socioeconomic history, by modified Kupaswamy classification, it's upper middle class. They live in a pakka house, overcrowding present, good ventilation, filtered water, adequate hygiene, and no history of indoor smoking. Summary, a 1 year, 8-month-old male child, first child born to a 3rd degree consanguineous couple, immunized till date, informant being mother with good reliability, presented with complaints of cough since 1 week, hurried breathing since 2 days, and chest indrawing since 2 days. Child had 3 previous episodes of pneumonia. General physical examination, child is irritable and there's increased work of breathing. Examined in sitting position. The temperature was 97.5 degree Fahrenheit measured in the axilla. Pulse 100 beats per minute, regular rhythm, good volume, no radio delay, other pulses fed. Blood pressure is 100 by 60 mm of Hegde measured in the right arm sitting position. Respiratory rate was 64 cycles per minute. Subcostal, intercostal, and suprasternal retractions present. The SpO2 was 88%. Head to toe examination. And the nose, the nasal flaring was present. And upper left arm, the BCG scar was seen. Anthropometry, the weight which was expected was 11.5 kg, but observed was 8 kg. Length expected was 88 centimeter, observed was 76. Head circumference 47 centimeter, chest circumference 49 centimeter. Mid upper arm circumference 20.5 centimeter. And the weight for length, in this standard deviation, it came between -2 to -3. Systemic examination, respiratory system, upper respiratory tract, nose, nasal flaring was present, normal in shape, oral cavity was normal, tonsils not enlarged, posterior pharyngeal wall normal. Lower respiratory tract, inspection, respiratory rate 64 cycles per minute, subcostal, intercostal, suprasternal retractions present, trachea appears to be central, chest normal in shape and size, apical impulse not seen, chest moves equally with respiration, no dilated veins or sinuses. Palpation, the position of trachea is central, chest movement symmetrical. Apical impulse left, fourth intercostal space, 0.5 centimeter lateral to the midclavicular line. Percussion, it was resonant in all the lung fields except in the in the mammary area on the left side, which is the cardiac tunnels. Auscultation, it was a vesicular breath sounds, but in the infraaxillary, infrascapular region, there was bilaterally equally reduced, and crepitations were also felt in the infraaxillary, infrascapular region on bilaterally. Other system, CVS, S1, S2 heard no murmurs, CNS no focal neurological deficit, per abdomen soft, non-tender. Summary, on examination, child was irritable, sick-looking, afebrile with increased work of breathing and tachypnea, not able to maintain the saturation. There's moderate acute malnutrition along with chronic malnutrition. There's reduced air entry and crepitations in infraaxillary, infrascapular regions on both sides. Provisional diagnosis, it's a case of a recurrent pneumonia with moderate acute malnutrition and chronic malnutrition. Probably the cause could be because of defects in the clearance of the airway secretion. And the differentials we're thinking is cystic fibrosis or ciliary dysfunction. Thank you.
Okay, Nisarga, good presentation. You go back to your first slide. So this child has come with a cough, hurried breathing, and chest. Did he not have fever?
No complaints of fever.
No complaints of fever. Okay. Next slide.
Yes.
So if there is no complaint of fever, the previous episodes were also not associated with fever?
Previous episodes, ma'am, like the first and the second, they did not inform. And the third also, they were not able to inform, ma'am. It was not there. Most complaints were these cough and hurried breathing.
Most only cough and hurried breathing. So, what do you think here?
Ma'am, I think because of the repeated, like there are already this could be a fourth episode of like a pneumonia. So it's a recurrent pneumonia. So there could be some like underlying problem which has to be like monitored.
No, there is no fever in most of the episodes.
Yes, ma'am.
So do you want to give significance for that, or is it okay? Still you want to think of pneumonia?
It's a small child, like of the age 1 year, 8 months. So like fever is not very important.
No, fever is important because mother will have noticed fever unless it's a viral pneumonia. Was the child sick looking, or according to you was a sick looking child? So yes. If he's a sick child without fever, then that is something we need to work on. Can we explain absence of fever in this child? We'll presume it is pneumonia only.
Okay. Yes, ma'am.
How to explain absence of fever?
Yes, ma'am. If there's any etiology, like a viral etiology, sometimes they might not present with fever.
Anything else? In a malnourished children, do they present with fever? Yes. When they have infection,
no, ma'am, they do not present with fever because there could be, even because of the immunodeficiency and all, for that the immunity power could be little low. That's why they might not be able to present with fever.
So in fact, how do they present when they have infection? They present with
when
what?
They'll be sick. They'll be
what
very
will
like
be the temperature like? Temperature like?
Yeah, there could be hypothermia, either normal or there could be hypothermia.
When do you say hypothermia? What should be the temperature?
We say it'll be less than 35.5 degrees Celsius.
Yes. So maybe here it is just a viral pneumonia, or there is no pneumonia at all. There is some underlying lung pathology, or because of malnutrition he is having. How is he in between the episodes? Does he continue to have hurried breathing and chest retraction, or he is totally normal in between the episodes?
Because it is since 2 days. So the mother could not say anything much. She got scared because there was reduced activity. So she bought the child.
So that means in between also he continues to have little bit hurried breathing, which is worsening on and off. Then you will have to think of some pathology in the lungs itself rather than the pneumonia. Yes, next slide. Next slide.
Yes, ma'am.
No history of bluish discoloration. Okay, yes. Yes, next slide. What is the definition of recurrent pneumonia?
Okay, if there are any 2 episodes of pneumonia in 1 year, or there are 3 episodes of pneumonia, which is in any time frame.
With something. In what you said,
With, if there is no radiological, there should between each episode, the radiological clearance should be. Then the child should be like there should not be any symptoms.
You understood that point. So that differentiates between a persistent pneumonia and a recurrent pneumonia. So do you have any X-rays in between that the child is having normal X-rays in between?
Yes, ma'am. They showed us some of the X-rays. It was normal.
Where it was normal. So this is more a recurrent pneumonia than a persistent pneumonia. So give me some causes for recurrent pneumonia in a child.
There could be because of any congenital malformations. There could be because of the problems in the airway. Then and there could be because of cleft palate, and there could be because of any aspiration syndromes like even gastroesophageal reflux disorder. And if there is any immunodeficiency, primary or secondary immunodeficiency, that can also cause recurrent pneumonia.
Anything else?
And if any, if there is any problem with the secretions to like be cleared, so that's why we
common causes. What is the age of the child?
Age of child is 1 year 8 months.
So 1 year 8 months common cause.
I mean, foreign body inhalation can cause, and even asthma can cause.
Asthma is a DD, not a cause for recurrent pneumonia. It's a differential diagnosis. Okay, so foreign body aspiration. Then which type of cardiac disease will present with recurrent pneumonia?
Oh, yes, ma'am. It is left to right shunt diseases causes, which is acyanotic congenital heart diseases can cause recurrent pneumonia.
Example?
ASD and VSD.
Does ASD present with recurrent respiratory tract infections?
No, VSD mostly. VSD, ventricular septal defect.
Is ASD a left to right shunt? Is ASD a ACHT with left to right shunt?
Yes, ma'am.
Then why it doesn't, though it is a ACHT left to right shunt like VSD, why it doesn't present with recurrent pneumonia like VSD?
I'm not sure, ma'am.
Okay, fine, no problem. Next slide. Go to socioeconomic history.
Yes.
Socioeconomic history. You said there is no history of. I appreciate that you have taken for indoor smoking and all that. What are the most common causes for indoor pollution in the present day?
In the present day, ma'am, one could be because of the smoking. If any member in the house is smoking indoors.
I appreciate for that.
And like previously and all, firewood and all used to be used, ma'am, but now it's not.
Yes, in the present day was my question. Previous time, yes. But now nobody is using biomass fuel for cooking now. Most houses they are not using. So present day, what is it? Your mosquito coils, mosquito mats should be asked. One mosquito coil is equal to smoking 100 cigarettes. So you should ask for this also for indoor pollution. Yes, next slide. Next slide. Okay. Yeah, so this child is having tachypnea. What is tachypnea for a 1 year 4 month old child?
For 1 year 4 month old child, if it is more than 50 cycles per minute.
So what is tachypnea you tell across different age groups?
Yes, ma'am. If it is from if it is from like 0 to 2 months, it's more than 60 cycles per minute. Then 2 months to 1 year if it is more than 50 cycles per minute, and 1 to 5 years if it is more than 40 cycles per minute.
So in this child, more than 40 is tachypnea. So 64 cycles is tachypnea. You have written subcostal, intercostal, and suprasternal retractions. What does subcostal retraction indicate? What does suprasternal retractions indicate? Generally, I'm talking generally.
Oh, okay. Now I'm not very sure.
In pneumonia, do you get a subcostal retraction or an intercostal retraction? Which is specific for pneumonia?
It'll be subcostal retraction.
Yes, subcostal retraction. If you are having more of suprasternal retraction, what does it indicate?
It indicates maybe because of some upper lobe pathology.
Upper airway, upper lobe, upper airway involvement.
Upper airway pathology.
Okay. Next slide.
Yes.
So he is also having nasal flaring. What are the other evidences of respiratory distress in a child apart from nasal flaring?
there could be noisy breathing. And
noisy
there could
breathing
be,
is non-specific. I told that time. Specific evidences of severe respiratory distress.
If there is the hypoxia, there could be the cyanosis will be.
Yes, next. Before cyanosis. One will nasal flaring, subcostal retraction, like that. Anything else? Grunting. Does it indicate respiratory? This
yes,
expiratory or inspiratory grunting? Grunting is expiratory or
expiratory.
Expiratory. There are few more are there. It's okay. Next slide. Next slide. Yes. When you write anthropometry, you have put your interpretation in the end. Here only you should write. What are the points to say that he is having moderate acute malnutrition here?
Oh, yes, ma'am. The weight for yes, ma'am. The weight for the age, it's coming between -2 to -3 standard deviations. So that is coming under moderate. And then the mid upper arm circumference is also 12.5 centimeters.
What
so
is weight for height, not weight for age? I heard it as weight for age.
Ma'am, the first parameter, weight for age, ma'am.
No. What is suggestive of ma'am in this child? What is suggestive of ma'am?
Okay. Ma'am, the weight for length or the weight for height, if it is between -2 to -3 standard deviation, it tells us about wasting. So that is giving an indication of malnutrition.
Good.
And even the upper arm circumference.
Yes.
Ma'am, it's like 12.5 centimeter. If
between
it is between
what
12. Yes, ma'am. Between 12.5 and 13.5.
You call it ma'am?
That is like moderate.
No. When do you say ma'am based on mid-arm circumference? When do you say Sam based on mid-arm circumference?
If it is less than 11.5 centimeters.
When do you say ma'am? Moderate acute
11.5 to 12.5.
11.5 to 12.5. So if it is less than 12.5, then you can take it as moderate. This is just coming borderline. Okay. Yes. And what has happened here? Chest circumference and head circumference, is it okay?
Yes, ma'am. Head circumference is normal. Chest circumference is normal. Ma'am,
Yes,
the length is very less. Length
So
is
what
very less.
does it-
It's like going a -3 standard deviation. So there is stunting. So it's giving an idea of chronic malnutrition also.
Yes, fine. Good. Next slide.
30 seconds more.
Okay, fine. I think in your RS examination, except for bilateral crackles, you have not, and tachypnea, you have not got any positive finding. How do you approach this? Now you have put this child as, go for your impression. Recurrent pneumonia due to, next, impression, final slide.
Yes, ma'am.
Probably due to, you said cystic fibrosis and immotile cilia syndrome. So how do you approach a recurrent pneumonia?
Yes, ma'am. So we try to rule out all the causes, ma'am. If any anatomical causes, there was already a HRCT done, and in that they did not show any abnormalities in the.
Don't go for investigations. Clinically, you discuss.
Yes, ma'am. And then we asked for any aspiration symptoms, like for gastroesophageal reflux disorder. We have asked if there was any regurgitation, feeds, or any difficulty in swallowing. So that we try to rule out any aspiration. And even immunodeficiencies, we asked any repeated infections involving other symptoms. Here, as of now, we only know that it is involving the respiratory system. We asked if there is any skin infection, if any ear infection, and also we are trying to rule out. And even any high risk like behavior and all in the parents, like we asked about blood transfusion and all. So we are not getting an idea of any vertical transmission of.
What investigations you want to do in this child? Specific investigations.
Yes, I'm like now because there is pneumonia and also either the gastric aspirate or the bronchoalveolar lavage we can do for the culture, and so that we can start with the treatment. And since we are thinking that because any airway secretions and there is any defect in the clearance of airway secretions, so we could do a sweat chloride test. If it comes more than 60 milliequivalents per liter, then we could suspect cystic fibrosis. And then the other normal ESR, complete blood count and all can be done. And if for any aspiration and all, we can do a barium study that can be done. And if in ciliary dysfunction, electron microscopy study can be done.
See, they are all costly. If patient is affordable, that is fine. Basically, how do you approach is you cannot do all investigations in that patient. How do you approach is you should find out whether the recurrent pneumonia is affecting same lobe again and again, or is it affecting different lobes at different times. If it is affecting same lobe again and again, you think of an anatomical defect, then go for bronchoscopy. If it is affecting different lobes, then think of systemic cause. Okay. Okay, thank you.
Presenting the case of a 10-year-old boy born on 25th November 2011, educated up to class 3, a resident of Delhi, and history was...
Again, no, you take from the same complaint. You take from the side panel. Otherwise, if you move the slides, it will not be visible for us. Try to make it slideshow. If you cannot make it slideshow, then take from the side panel.
Ma'am, are they moving now?
Yeah, that is, if you take from the side panel, it will move. You just click on the button, it will not move. Yeah.
Okay,
yeah, it's smooth. Yeah.
Okay, ma'am. The date of admission was 30th November 2021 and the date of examination was 1st December 2021. The patient presented to the OPD one day back with chief complaints of history of progressive pallor noticed by the mother since 1 month, bilateral swelling of feet since 20 days, and generalized abdominal distension since 15 days. The patient was apparently well 1 month back since the mother noticed paleness of the child's face, insidious in onset, progressed over the past 1 month, and associated with easy fatigability and lethargy in the child. The mother reports the child started avoiding physical activity, and the child is also reported to have found eating mud by the mother on several episodes. From 20 days, the child started having swelling of both feet, which was insidious in onset, progressed gradually over 2 to 3 days to involve half the leg. It was more in the evening and exaggerated on exertion and relieved on rest and elevation of leg. No associated pain, redness, or discoloration. In 5 days, the swelling progressed to generalized abdominal distension, which was insidious in onset and gradually progressed over past 15 days. No significant shortness of breath and decreased urine output was noted by the patient. The patient was admitted at the time of presentation and was put on oxygen and IV medication. Blood transfusion was given according to the mother. Negative history. There is no history of puffiness of eyes, frothy urine, cola-colored urine, or burning micturition, altered mental status, or decreased urine output. No change in frequency or consistency of stool, vomit, or abdominal pain. There is no history of yellowish discoloration of eye, right upper quadrant pain, fever, or myalgia. There is no cough or noisy breathing. There is no history of any episode of cyanosis since birth, recurrent pneumonia, fainting episodes, chest pain, or similar complaints. No history of fever, joint pain, repeated IM injections 3 weekly. No fever, rash, or upper respiratory tract infection. There is no history of any loss of blood from any site, no change in color of stool, no trauma, no worms in stool, drug intake or any recent infection, pain in abdomen, or yellowish discoloration. Patient is not a known case. There is no significant past history. There is no history of blood transfusion. The antenatal, natal, and postnatal history were normal. The patient is developmentally normal and has achieved all the milestones in gross, fine motor and language domains adequate to age. Patient is fully immunized up till date and has no significant side effects associated with any of the vaccines. Had a 43% deficit of calories and a 30% essential food groups like pulses and green vegetables, and patient is not balanced. No significant personal history. The patient belongs to lower socioeconomic class according to modified Kuppuswamy scale. The child is conscious but appears lethargic and oriented to time, place, and person. The examination was done after consent of child and in a well-lit room. The vitals, temperature was 98.4 degrees Fahrenheit in the axilla. The pulse was 98 beats per minute in right radial artery in supine position. Normal rhythm, no radioradial femoral delay, respiratory rate was 20 per minute. The JVP was raised and found to be 4 centimeters of water above the sternal angle. Anthropometry, the BMI lies between -2 to -3 percentile, the second and the third percentile, and it is thinness according to WHO. Head-to-toe examination. In eyes, pallor was present in the bulbar conjunctiva. No signs of vitamin A deficiency like white hot spots, conjunctival or corneal cirrhosis. No icterus was present. No facial dysmorphism. The oral mucosa is dry and normal. The pallor is noted in the tongue with loss of follicles, bald tongue. no deformity in the nose, no other significant findings in the neck, apart from prominent neck veins which were present. The palms appear pale, flattened nails were present, no hyperpigmentation of knuckle, pedicure, purpura, no erythema marginatum on the skin, no abnormality of digits and hands. Pitting edema was present in bilateral lower limbs, external genitalia was normal. In the cardiovascular examination, the apical impulse was 2 centimeter lateral in 5 o'clock position of the nipple. On palpation, apex beat in the 5th intercostal space, 1 centimeter lateral to the midclavicular line, hyperdynamic in character. No other significant findings in inspection or palpation. On auscultation in the mitral area, S1 has 2 heard, and an injection systolic murmur of grade 3 intensity was present. S3 was present. No significant findings in other areas. On respiratory system examination, bilateral crepitations were heard. On abdominal examination, on inspection, the abdomen was uniformly distended with flanks full. And on palpation, on deep palpation, the liver is palpated 6 centimeter below the costal margin, smooth surface and margin, soft in consistency and tender. The liver span is 11 centimeter and shifting dullness was positive. Summary, a 10
video on. Video on.
Okay, actually my net is fluctuating because of that.
Yeah, it's okay.
Okay, it's okay. I think it can be only with audio, no problem.
Yeah, continue. Continue.
A summary, 10-year-old male, fully immunized, developmentally normal, presenting with progressive pallor since 1 month and generalized distension of abdomen and feet since 15 days with history of pica, has without any GI or hepatic or renal localizing symptoms with micronutrient deficiency in diet and 47.7% calorie deficit and protein deficit of 30%. On anthropometry, the child has thinness and signs of iron deficiency are present. The JVP is raised, and on systemic examination, apex beat is shifted outwards and downwards, and S3 and ejection systolic murmur are heard. Basal crepitations are heard on respiratory examination. On abdomen, hepatomegaly and shifting dullness is present. My case, most likely in a 10-year-old boy with thinness, fully immunized, developmentally normal on the basis of history and examination is congestive heart failure due to severe anemia, most likely nutritional origin. Thank you, ma'am.
Okay. Harshita, go back to your first slide.
Yes, ma'am.
Yeah. Now he is 9 years old child who has come with progressive pallor from 1 month. So what are the causes for progressive pallor in a 9-year-old child?
Ma'am, the causes would be anemia. And then there are several types of anemia like hemolytic anemia.
In this child, in a 9-year-old child, go from most common to least common.
Yes, ma'am. Ma'am, there could be a nutritional cause, iron deficiency anemia. Secondly, hemolytic anemia, which could be thalassemia or a sickle cell anemia could also be present. And other causes like dietary malabsorption syndromes like celiac disease could also present in a 10-year-old child.
What is the common age group for nutritional iron deficiency anemia?
Ma'am, nutritional iron deficiency anemia in children mostly occurs during the time of weaning, when there is inappropriate weaning and when the cow milk is given. So fine. During that time, it's the peak time.
So 6 months to say 3 years, 6 months to 2 years is one. Any other peak?
Ma'am, during the puberty and in females, the menstruating and the growth spurt.
So in adolescence. So he is neither in that age group, neither nor in adolescence. So he is not an age group for nutritional anemia as of now, but still okay. But what then you said hemolytic anemia, thalassemia. Which thalassemia presents with severe pallor that mother notices and comes with failure?
Ma'am, ideally it should be thalassemia major, but that would not present at 10 years.
So when beta thalassemia
they would have
presents?
been repeated blood, ma'am, by early 1 year or
6 months to 1 year of age.
Yes, ma'am.
First year. So this is not the age group. So both your first BDs are not convincing for me. So you are thinking of celiac disease. Anything else in this child? Progressive pallor? Any other cause?
There could be a lymphoreticular malignancy as well.
Yes. Which is the most common malignancy, hematological malignancy in this age group?
Ma'am, ALL.
Yes, good. So it could be malignancy like ALL.
Yes,
Any other condition where there is reduced production marrow involvement? Aplastic anemia. Aplastic anemia.
Or there could be.
Yeah, tell me.
Or ma'am, there could be a hookworm infection, which is again common in children and coming from a rural area. It is
yes. Okay. Okay. Yes. And any non-hematological cause for severe anemia in these children?
Ma'am, apart from malabsorption syndromes,
renal cause, chronic renal disease, chronic
yes,
kidney disease,
chronic kidney disease.
Yes. Okay. Right. Yes. Next slides.
Yes, ma'am.
Yeah, I think what are the symptoms of left heart failure and symptoms of right heart failure?
Ma'am, left heart failure can present with palpitations in a child, or decreased cardiac output could lead to syncopes and fainting episodes.
Pathognomonic symptoms of left heart failure. See, palpitations can be there in many other regurgitant lesions without failure. So, pathognomonic?
Ma'am, syncope and fainting.
Syncope can be there, aortic stenosis, orthopnea and
PND.
That is very like pathognomonic for left heart failure. Right heart failure is?
Ma'am, in right heart failure, there'll be back pressure changes. So edema, abdominal distension, JVP raise.
Good. Yes. Okay. Continue. Examination. Go for examination.
Yes.
Okay. Now his JVP is elevated, you have written, and he is having thinness. Yes. Next.
Yes, ma'am.
Okay. Then he is having anemia, pallor. Okay. Next.
Yes, ma'am.
Now another thing is, continue. Next. You said he is having go for a per-abdomen cardiovascular. What is the cause? Next slide. You said next slide. You have put an ejection systolic murmur in mitral area.
Yes.
What is the cause for that ejection systolic murmur in mitral area?
Ma'am, the cause of ejection systolic murmur is a hyperdynamic circulation. This is most commonly seen in the pulmonary area because of hyperdynamic circulation.
So why you put it in mitral area then?
Ma'am, because it can be present in the mitral area as well if there's functional mitral stenosis due to hyperdynamic circulation, and this was found in the patient. So,
functional mitral stenosis, what murmur you should get?
Ma'am, mid-diastolic murmur. Okay.
This ESM hemic murmur is always in the pulmonary area.
Right.
And what is the cause for S3 here?
Ma'am, heart failure.
Yeah, S3 is for heart failure. Yes, okay. Then you have written bilateral crepitations. What is the recent term used for crepitations in all the clinical methodology books? We don't use the term crepitations. You should use the word crackles.
Crackles, okay.
And you should write what type of crackles. What type of crackles you get in failure?
Ma'am, coarse crackles.
Coarse, huh? Where do you get coarse leathery crackles?
Pneumonia.
Bronchectasis, coarse leathery crepitations or crackles. In failure, you get fine crepitations. So that should be written. Crepitations or crackles. Yes, next. Next slide. So you have written there is a shifting dullness and all that, no?
Yes.
So what is the next slide? So what is the cause for shifting free fluid in abdomen?
Ma'am, because of increased pressure in the central venous system, there is exudation of fluid which resulted in the abdominal distension. So
is it common with acute heart failure or chronic heart failure?
Ma'am, it is more a sign of chronic heart failure.
Chronic CCF, you get ascites. Otherwise, acute CCF, it's not a very common entity. Okay, yes. So how do you go? What's your diagnosis?
Ma'am, my diagnosis is most likely congestive heart failure. Yes, ma'am. Due to severe anemia, most likely nutritional and etiology on the basis of history and examination.
So what investigations you want to do?
Ma'am, first of all, I would ordering for a chest X-ray and basal routine investigations like the complete blood count, electrolytes, LFT, KFT, because the patient is in heart failure.
What should be the HP percentage to say pneumonia according to WHO in a 9-year-old child, 10-year-old boy?
10, yes, ma'am. Ma'am, less than 11.5 gram per deciliter.
Good. Now, what will be the peripheral smear picture like if it is nutritional anemia?
Ma'am, I would be expecting a microcytic hypochromic anemia.
What are the other causes for microcytic hypochromic anemia?
Ma'am, there can be iron deficiency anemia, thalassemia, anemia of chronic inflammation, or sideroblastic anemia.
Okay. Yes. How do you treat an iron deficiency anemia?
Ma'am, iron deficiency anemia can be treated by oral iron supplementation. And if the patient does not tolerate or is non-compliant to an oral iron supplementation, then we would choose a parenteral iron.
Parenteral is rarely used in pediatrics.
Where severe anemia.
Yes, how much you give oral iron therapy?
Ma'am, oral iron, I'm not exactly sure of the dose.
How long you treat?
Ma'am, we treat, we monitor the complete blood count and we treat after 6 months after the complete blood count has been normalized so that the stores can also be filled.
It's not 6 months. What you're telling concept is correct, but duration is not correct. Huh? Okay, you just cross-check that. Okay, thank you.
I myself, Sharad, currently at final year MBBS from Madras Medical College at Chennai. Coming to the, I put it in slides. Coming to the history of chief complaints, master named ABC, a 10-month-old child coming from the region of Ambattur, the first-born child belonging to lower middle class, was brought by his mother, who has given a fairly reliable information, has presented with the history of stiffness of all 4 limbs noted since birth, and has not attained age-appropriate milestones. History of presenting illness. History of stiffness of all 4 limbs noted since birth, which was progressively increasing in nature. History of fisting of both upper limb and history of scissoring of both lower limb. History of difficulty in putting diapers and trousers. And there was history of turning to one side. And then there is no history of any abnormal movements or no history of any vomiting, feeding discrepancies or poor weight gain. And then no history of any deformities, no history of recurrent respiratory tract infection or constipation. And there was a past history of seizure in the neonatal period for which the child was on anti-epileptic drugs. Child has a good interaction with mother and has a good night's sleep. Coming to the cranial nerves examination, mother gives history that the child is recognizing and following light. No history of abnormal eye position, no history of defective sucking, and no history of deviation of angle of mouth or facial asymmetry. Then the child responds to sound by turning. There is no history of regurgitation or pulling of secretions. No history of abnormal movements of tongue. Child is moving all the 4 limbs. Child is able to perceive sensation while breathing. Bowel and bladder control not attained. And coming to antenatal history, the mother was married at the age of 23 years, spontaneous conception after 1 month, no history of any abortion, and the first trimester was uneven full, no history of any drug intake or radiation exposure. And then in the second trimester, there is no history suggestive of gestational diabetes mellitus or preeclampsia. Iron, folic acid, and calcium tablets were taken. And good perception of fetal movements in the third trimester. And then, so there was uneven full throughout the 3 trimesters. Coming to the natal history, it was a full-term vaginal delivery at an subscale at a town GH. Birth weight was 2.2 kg. The labor was prolonged due to poor maternal effect and was delivered at forceps. The baby did not cry immediately after birth and was resuscitated with bag and mask ventilation. So admitted at the neonatal intensive care unit at Institute of Child Health, Chennai. Coming to the postnatal history, There was history of neonatal seizures after 7 hours of birth, there was a continuous 5 episodes during the stay in the hospital, for which the child was treated with anti-epileptic drugs. The child was done with an imaging and was reported abnormal and discharged with the request to follow up and treatment to the parents. No history of any difficulty in sucking and no history of neonatal jaundice, cyanosis, or birth injury. And coming to the developmental history, the child has attained neck holding early in the first month, and then there is no history of turnover, crawling, sitting or standing with support. Hand regard and ambidextrous reach are attained. No transfer of object, palm or pincer grab. Social and adaptive social smile attained, and recognizes mother. Other social milestones are not achieved. Vocalizing and cooing with respect to language milestones are attained. No laugh out loud, monosyllables or disyllables haven't been attained. Vision and hearing. Vision fixed at 4 weeks, and the child responds to calls. So the gross motor function development quotient is 62%, and with respect to fine motor, it is I'm just not able to see my own screen. Okay. Fine motor is with respect to 50%, and social domain is 50%, language as 80%. Diet history, the exclusive breastfeeding for 6 months, and after which complementary feedings were started. No significant family history. And then coming to immunization history, the child was immunized up to age according to the national immunization schedule. The last vaccine was at the 14 weeks. Sorry, it was wrong mention. And coming to the treatment history, the child was in the multidisciplinary approach and physiotherapy for 3 months. Coming to the summary, a 4-month-old child, first born with non-consanguineous marriage, term normal birth, weight baby, and has a history of delay in milestones and stiffening in all 4 limbs, with abnormal or uneventful perinatal period, with neonatal seizure and neonatal intensive care unit admission for 10 days. Probable system involved is central nervous system, and I wish to examine the central nervous system. Coming to the general examination, child is alert, awake, and quiet in mother's lap. And coming to the posture, there is adduction at the shoulder joint, flexion at the elbow, wrist, and the finger. There is presence of cortical thumb, and lower limb, there is an extension at the hip joint, and there is an adduction. Extended at knee joint, plantar flexion in the ankle joint, scissoring is noted. Head to foot examination.
30 seconds for examination.
Okay, I will finish it fast. Okay, microcephaly, and then anterior fontanel is open. And then there is no significant with head to toe examination. I'll coming to skin or spine are all normal. So vitals are all normal. Okay. And coming to anthropometry, the weight is not up to the age. The length and head circumference are not up to the age. These are the growth charts. I'll just finish off the CNS. Okay, CNS. All the cranial nerves are all normal with respect to examination. And then pull to sit, head lag is negative, and then ventral suspension, head lies beyond the body. Vertical suspension, scissoring of limbs, and there is a bulk equal in both upper limbs, so there is no wasting. And with tone, upper and lower limb, there is increased spasticity. And posture power 3/5 is best observed. And then the deep tendon reflexes are all exaggerated, and superficial Babinski tendons positive, corneal, conjunctival, and abdominal are positive. And then perimeter reflexes are retained at tonic neck reflex, palmar grasp, plantar grasp, and sucking are all retained. Child is able to perceive sensory pain sensation. Cerebellar system are all normal. Okay. And other system examination, RS and abdominal, are all normal. I'm just rushing up to time. I can come back to the discussion session. Okay. Professional diagnosis: a 10-month-old boy child with global development delay and microcephaly with non-progressive static motor deficit, most probably a case of spastic quadriparetic cerebral palsy due to intrapartum complications and hypoxic ischemic encephalopathy sequelae. Thank you so much.
Okay. Sharath, go back to first slide.
Yeah, definitely, ma'am. Is my screen visible, ma'am?
Yeah.
Yes.
So you are telling history of stiffness of all 4 limbs noted since birth. What do you think is the cause for this stiffness?
Ma'am, due to an I'm probably suspecting an cerebral palsy. So a pyramidal tract lesion is what I'm suspecting.
What do you call that stiffness due to pyramidal tract involvement?
Spasticity.
So now you think at birth only you will get spasticity. When spasticity appears in a spastic CP, at what age?
It usually develops after a period of 3 or 4 months.
Usually after 6 months to 1 year. After 6 months only spasticity will develop. You have written notice since birth. So what, this is not spasticity then? What is the cause for this?
Could be due to an neurodegenerative disorder, could be a differential diagnosis.
No. How do you differentiate CP from neurodegenerative disorder?
Ma'am, with respect to CP, there is a sequel A, and then with respect to history, the antenatal trauma or any assault type could be noted, and when during the perinatal also it could be noted. But in case of neurodegenerative disorders, there is no clear history with respect to antenatal or perinatal. The child presents with after birth, it is noticed after birth with the sequel is noted.
In CP, what percentage will have a history of perinatal insult?
It is only 15%.
You are only telling, no? Less than 50%, less than 10% will have birth asphyxia. 90% will not have any perinatal insult. Then how do you differentiate that 90% from NDD, neurodegenerative disease?
With respect
what is a pathognomonic history in neurodegenerative disease?
Ma'am, there could be an family history positive.
Even in cerebral palsy you can get. Only thing is in neurodegenerative disease there will be regression of milestones. Here you don't get regression of milestones. Okay, go for the next slides.
Okay.
So he is having scissoring. What is the cause for his scissoring?
Ma'am, it is due to the pyramidal tract involvement.
But then he can have anywhere, no? Why he should have typically scissoring? Or which pyramidal tract involvement causing which muscle involvement?
Muscle most involved is the quadriceps muscles are involved.
No, quadriceps. It is due to adductor spasm. It is the adductor group of muscles. Okay, continue next. So cranial nerves are all normal, no?
Yes, ma'am.
Yes, next. Motor is okay. Next.
Antenatal.
Antenatal, you said he is not cried immediately after birth.
Yeah,
okay?
yes, ma'am.
Yes, he was admitted in NICU and he had some seizures and all that.
Yes, ma'am.
Okay, I'll come back to that. Back to that. Go back. Go continue. Next
yes,
slide.
Yes, ma'am. Sure.
Next slide. Now, when do you say global developmental delay? Does this child have global developmental delay? Because your language milestone is normal.
Yeah, yes, ma'am.
So when do you say what should be the DQ to say developmental delay? Is 80% normal or abnormal?
80% is normal, ma'am. We should have an -3 standard deviations.
No, you have put a DQ, no?
Yes,
there is some figure you have put 62, 50, 50, 80.
Yeah.
So how much is to be taken as delay in each domain? DQ below how much is to be taken as delay?
Can be taken as 50%.
No, it's below 75. Some books say 70 also. 80 is definitely normal. So 80 is normal. That means language is normal here.
Yeah.
So can I call it global developmental delay in this child? Because in your final summary, you have written global developmental delay.
Yes, ma'am. But the other milestones have not been achieved yet, ma'am. Laugh out loud and monosyllables.
So how many milestones should be delayed to say global developmental delay?
It should be 2 milestones.
But gross motor, fine motor is taken as 1.
Yeah, yes, sure.
So gross motor, fine motor are delayed, then you cannot take two. Taking gross motor and fine motor as one, another domain delayed is taken as global developmental delay. So this child is having GDD. Next, examination.
Okay. Yes.
You said your child is having microcephaly. What is the definition of microcephaly?
Microcephaly is defined as the head circumference less than third percentile with
Is it
respect
percentile or standard deviation?
to sorry, it's standard deviation minus
What
3
is
standard.
the difference between percentile and standard deviation?
Ma'am, standard deviation with is respect to the bell curve, and then where there is a standard refers are fixed, and then the measures are taken. Percentile with respect to the highest percentage attained with respect to that we care with the age.
Third percentile is equal to how much standard deviation? Okay, no problem. Continue.
Yeah.
CNS examination. Tell me orally. You tell me what are the positive findings in CNS examination. There is a cortical thumb.
Yeah.
Okay?
Yes, ma'am.
Yes. Next.
There is a cortical thumb, and then we are not nice. Come to that. Okay, the cranial nerves are all normal now, and then coming to the
findings you tell.
Yeah, sure, ma'am. And the tone is increased in the upper
there
and lower
spasticity.
limb. Spasticity. And then there is an brisk reflexes with respect to upper limb. And then there is an Babinski sign is positive.
Yes. Next.
And then there is a preservation of primitive reflexes, tonic neck reflex, palmar grasp, and plantar grasp for all.
When Moro's wrist reflex disappears?
It should disappear by 5 to 6 months.
But it is absent here. What does it indicate?
Yes, ma'am. The child has certain development, but till 6 or 7 months, then the child has undergone some regression, and then it has become static.
No. There is no regression. No, history-wise, there is no regression of milestones.
Yeah, history because the poor follow-up of the parents. So that is the reason.
No. History-wise, they should tell regression of milestones. Then only you can take it as regression. He is not telling regression. Yes. Go for your final impression.
Yeah, sure.
One more minute.
Yes, fine. I'll finish. So now global developmental delay, microcephaly, non-progressive, spastic, quadriparetic, cerebral palsy. See, now can they, with this diagnosis, the parents will go and sue the gynecologist. You have caused birth asphyxia for my child.
Yeah, yes, ma'am. There is a
possibility. You have written CP due to birth asphyxia. So tell me what is the relation between birth asphyxia and CP? If you are a gynecologist, how you will support yourself, defend yourself?
Yes, ma'am. I will defend myself that the patient has some contraindications to spinal anesthesia and surgery. Then that is why the reason I have waited, and there was no consent from the family for LSCS.
No. You forget all those practical points. Here, most often CP is not due to birth asphyxia per se. Most often cerebral palsy is due to underlying cerebral malformation. The underlying cerebral malformation predisposes to birth asphyxia and also to CP. So what investigation you will do to pick up cerebral malformation?
From cerebral malformation, I will start with an CT, ma'am.
CT or MRI, which is better?
MRI will give me more fine details.
So you should go for MRI.
MRI.
Then what is the management? Tell me one word for management for this child. Last question.
It will be a multidisciplinary approach.
Okay. Thank you.
Thank you so much.
Yeah, good evening.
Present. a patient, Mr. ABC, aged 4 years old, hailing from Chikmagalur, presented to our hospital. He is a known case of a blood disorder requiring regular transfusion since 7 months of age. He has currently presented for a routine blood transfusion. The history of presenting illness. The patient was apparently well until 7 months of age when he developed a fever. The treating physician noticed pallor. The blood tests showed low levels of hemoglobin. Further investigations revealed that the child was suffering from a blood disorder and would require regular blood transfusion. The first transfusion was at 7 months of age, and post this, the child needed a transfusion every month till 2 years of age. Currently, the patient needs a blood transfusion every 3 weeks. The child tolerates the transfusion well with no history of fever, chills, or rash during the transfusion.
Your slides are not moving.
1 minute, ma'am. Sorry.
Yeah, it's okay. You can keep like this and take from the side panel.
I'm sorry. Is it visible now, ma'am?
Yeah.
Currently,
click on the side panel.
Yes, ma'am. Currently, the patient needs a blood transfusion every 3 weeks. A child tolerates the transfusion well with no history of fever, chills, or rash during the transfusion. There is no history of irritability and fatigue, no recurrent infections, no history of bleeding manifestations, no history of joint pain, swelling in fingers and toes, yellowish discoloration of skin or eyes. There is no history of poor weight gain, reduced appetite, or any blood transfusion history in the family. The child takes 1 tablet per day in the early morning on an empty stomach from 2 years of age. The past history, the child has previously been admitted to the hospital only for regular blood transfusion. The last transfusion was done on the 9th of November. The birth history was uneventful. The development history, age-appropriate development milestones have been achieved. The immunization history, it is up to date as per the national immunization schedule and no special vaccinations were taken. The family history, the child is a second child of a 3rd-degree consanguineous marriage. Post the diagnosis of the child, the parents have undergone testing and they have been found to be carriers of a blood disorder, not requiring transfusion. The elder sister is healthy and testing revealed no blood disorder. No history of a blood transfusion, yellowish discoloration of skin, any abdominal surgery in family members. The diet history, patient consumes a mixed diet with adequate calorie and protein intake. This is a sample diet that the child consumes. The general physical examination, examined in adequate daylight with consent from the parents. Patient is conscious, cooperative, and oriented to time, place, and person. The face is normal, skin is normal, pallor is present. Icterus, cyanosis, clubbing, pedal edema, and generalized lymphadenopathy are not present. The anthropometry. The height of the child is 105 centimeter, which is normal for this age. The weight is 15 centimeter and the weight for height is 93%, again normal for this age. This was the growth chart inserted. The vitals, the pulse rate is 120 beats per minute, BP 104/60 millimeter Hg, respiratory rate 28 cycles per minute, temperature 98.6 degree Fahrenheit. The systemic examination, the per abdomen, the shape is normal, the umbilicus is central, the quadrants move equally with respiration, no scars are seen. Soft, tender on palpation, the liver, soft non-tender on palpation. The liver is palpable 5 centimeter below the right costal margin, smooth surface, sharp border. The span is 8 centimeter. The spleen is palpable 3 centimeter below the left costal margin, firm in consistency with sharp border. Bowel sounds are heard. On examining the abdomen of the mother and father of the child, the spleen is not palpable. The other system examinations, CVS, S1, S2 heard, respiratory system, normal vesicular breath sounds heard,
Move
and
your slides. Move your
CNS,
slides.
no focal neurological deficit. Provisional diagnosis, a 4-year-old child born of a 3rd-degree consanguineous marriage with anemia and hepatosplenomegaly, requiring a blood transfusion requiring regular blood transfusion presented to our hospital. Given this history and examination, I would like to consider a diagnosis of transfusion-dependent beta thalassemia major.
Good, Karina. Go for your first line. Yes.
Pardon, sir?
Yeah,
Pardon,
go for
ma'am?
your first slide.
Yes,
First
yes.
line. So he is a 4.5 years, 4 years, 2 months old child.
Yes.
And why you have mentioned community? Usually we don't mention.
Ma'am, for certain blood disorders, it is prevalent in certain communities. So for the disease that I am thinking of, then it is more prevalent in the Sindhi community, in the Gujarati community, Lohia community.
Okay, fine.
Next
slide. Next slide. So tell me some conditions apart from hemolytic anemia where you give regular blood transfusions.
Okay, yes, ma'am. One disease could be osteopetrosis or an aplastic anemia or a failure of the bone marrow.
Failure of the bone marrow is aplastic anemia. Any
Yes.
non-hematological cause?
Osteopetrosis.
That is also sort of hematological only, no? Non-hematological? We discussed with the previous student. Chronic kidney disease.
Chronic kidney disease, yes.
Chronic kidney. Now this child has presented at 7 months of age. So what is this age group telling you about?
This age group would usually tell me about hemoglobin-based disease in the synthesis of the hemoglobin when it's shifting from HbF to adult hemoglobin.
Yes. So when does thalassemia major present? When does thalassemia intermedia present?
Thalassemia major usually after 6 months, and thalassemia intermedia after 1.5 years to 2 years.
Yes. Okay. Next slides. Yes. When do you start thinking of iron overload? Since 2 years of age, that is from past 2 years, he is on BT.
Yes.
So when will you think of iron overload?
Ideally, we will ideally after 10 transfusions is when we have to think of an iron overload and do the serum ferritin. And if it is, so if we have started at 6 months, that would be 1 year, 4 months when we would do the ferritin. If we are getting the value above 1000 nanogram per ml, then we have to tell the patient, parents of the patient that we need to start chelation therapy, though it is not recommended until child is above 2 years.
Yes, okay. Continue. Next. Yes, okay. This you can skip negative histories. Yes, next. And you said child takes 1 tablet early morning on empty stomach.
Yes.
So can you tell some tablets which are taken on empty stomach?
Ma'am, Defersirox, Pantoprazole.
Any other drugs we take on empty stomach?
Insulin before food.
No. Tablets, no?
Oh, tablet, sorry. Ma'am, it's not striking me, sorry.
Okay, no problem. We'll take pantoprazole only. How you will say that this is not pantoprazole and it is Defersirox?
Okay, ma'am. This child has been taking it from 2 years of age on a daily basis.
Okay. And what is the specific thing, how it is taken, Defersirox tablet? Do they swallow?
No, the tablet is taken and mixed in a glass container or a plastic container, not steel or aluminium or iron, and it is stirred in juice or water and then
that you should write there. Along with empty stomach, she is taking mixed with juice or water dispersed.
Yes, sure.
Like that. Yes, next. Continue. Okay, next. Family history. What is the mode of inheritance here?
Autosomal recessive, which is why the consanguineous marriage attains more significance.
Now you know that parents are screened and they are affected. What is the risk for the next baby? What all they want to have a next baby?
Okay, so if both the parents are carriers, then there is a 25% chance of having a child with thalassemia major.
Okay. Examination.
Ma'am, anthropometry.
Per abdomen, anthropometry is normal, no?
Yes.
Per abdomen examination.
Because the diet is also adequate, so anthropometry.
Yes. Per abdomen examination. See here, next slide. No, go back. You have written, no, per abdomen.
Per abdomen, yes, ma'am.
Per abdomen. Here, you have written liver is sharp margin, sharp border, and spleen also sharp border. Where do you get sharp border? When you will get? Now, what is the normal liver border like?
Rounded, ma'am.
When will you get a sharp border?
Not sure, ma'am.
No, if it is gone for cirrhosis, then you will get that sharp leafy margin like that. Okay. So I think this may not be really sharp border. For spleen also you have written sharp border.
Yes, ma'am.
And what is the grade of splenomegaly? How do you grade splenomegaly in children?
Depending upon its location, ma'am. If it's not palpable, then it's grade 0. If it's just palpable on deep inspiration, then it's grade 1. If it's before the umbilicus along the splenic axis, it's grade 2. At the umbilicus is grade 3. Beyond the umbilicus towards pubic symphysis is grade 4.
Beyond in right iliac fossa is grade 5.
Yes.
Including 0 is grade 5. Yes. Okay. Now go for your diagnosis. Transfusion dependent beta. What are the other differential diagnoses?
Ma'am, after taking all this into consideration, then I'm only arriving at transfusion.
No, everything only in consideration only. Could it be anything else?
It could be, but very unlikely, a sickle cell anemia.
What are the points against sickle cell anemia in this child?
One is the child is not having any swelling in the fingers and in the toes. There is no joint pain, abdominal pain, no history of any CNS manifestation like a convulsion.
Could it be hereditary spherocytosis?
Very unlikely, because that would have presented in the neonatal period itself, ma'am, and it can't be because we have examined the parents as well, and it's an autosomal dominant condition. So one of them would have had a palpable spleen or actually splenomegaly.
So how you will, I will agree. I'll give you marks for what all you said. But the points you have to simultaneously say is it has a varied presentation. Everybody will not present in newborn period. It has a varied presentation. They can even be asymptomatic with splenomegaly. So that is, and because there is no, even if there is no family history, spontaneous mutations may occur. Okay. So you can keep that as a second diagnosis in this child. Okay. How do you confirm? Now, one confirmatory investigation and confirmatory treatment. Definitive treatment.
Confirmatory investigation would be the hemoglobin electrophoresis.
Well, how much will be the HbF here?
The HbF would be more than 90 to 95%, ma'am.
Okay. Now what? Definitive treatment. Parents want a definitive treatment.
Okay. Then we have to counsel them for a hematopoietic stem cell transplant. And we have to identify a HLA matched donor, ideally a sibling or a parent is also okay if HLA matched. And we need to prepare them for this. Prior transfusions would require ideally irradiated RBC, and then we will give them transfusion.
Okay.
And 6
Thank you,
months of immunosuppressants after that.
Okay. Thank you, Karim.
Good evening, everyone. I am Karate, a final year MBBS student from PMSNR Sangli. So here is a 2-month-old male child, first child born of non-consanguineous marriage, Hindu by religion, resident of Kolhapur, whose informant was mother and is reliable. The date of admission and examination being 2nd December 2021. Came with the chief complaints of loose stool since 2 days and vomiting since 1 day. The baby was apparently all right 3 days back, following which he had loose stools, about 5 episodes on day 1 and 8 episodes on day 2, which was sudden in onset, watery in consistency, yellowish green in color, and non-foul spelling, moderate in amount, without blood or mucus, and not associated with fever. Mother also complains of vomiting on day 2, 4 to 5 episodes, 20 to 30 minutes after feed, and they were non-bilious. Mother also tells that urine output is less. Previously, the child used to pass urine 6 to 8 times per day, but now just passed urine 4 times per day, and today was no urine passed since today morning. Baby is also not feeding well and refuses to take any breast milk or lactogen feed. There is also decreased activity and the child has become lethargic. There is also history of outside food intake 3 days ago. There is no any history of excessive crying, fever, or stools with blood or mucus. No history of any medical or home treatment taken for this vomiting and stools. In the past, wellness visits were there for immunization, and there was a history of similar illness in the past at 1 month of age requiring hospitalization for 2 days, and IV fluids were administered. Family history. It is a nuclear family and there is no any significant family history. The antenatal history is uneventful. In birth history, it was a term institutional vaginal delivery at 39 weeks of gestation. Baby cried immediately after birth and no NICU admission was required, and birth weight was about 3 kg. Neonatal history, the breastfeeding was initiated after 30 minutes of delivery and the child was fed on demand. Developmental history, all the developmental milestones are attained appropriate for the child's age. Immunization history, the baby is immunized up to date according to national immunization schedule and no any optional vaccines were taken. Feeding history, the child was exclusively breastfed for the first 2 weeks after birth, after which the mother started lactogen feeds with intermittent breastfeeding because she was feeling that the breastfeeding was inadequate. Socioeconomic history, according to modified Kuppuswamy scale, they belong to lower middle class. The water supply is by municipal corporation. It is boiled and properly stored in covered pots. This water is used for lactogen feeds. So summary, a 2-month-old baby, first child born of non-consanguineous marriage, institutional vaginal delivery at term, belonging to lower middle class, according to modified Kuppuswamy scale, has achieved all the milestones and is immunized up to date, who is given lactogen feeds with intermittent breastfeeding, has presented with loose stools since 2 days and vomiting since 1 day. So from history, it is suggestive of acute gastroenteritis with dehydration. On general examination, the child was lethargic, lying on his mother's lap. The temperature is 98 degree Fahrenheit. Pulse was 190 per minute. The pulse was feeble. Peripheral pulses were also feeble. Respiratory rate is 35 breaths per minute. BP could not be measured and the capillary filling time was more than 3 seconds. Anthropometric measurements were taken and from this it was suggested that the child is acutely severe malnourished. In head-to-toe examination, head, scalp hair was normal, anterior fontanelle was sunken and not fused, posterior fontanelle was fused, neck and face appeared to be normal. In eyes, no tears were present and lusterless sunken eyes were there. Ear normal, dry tongue and lips, spine normal, skin turgor more than 2 seconds, chest appears to be normal, palm is pale in color, limbs appear normal and external genitalia normal. On systemic examination, in per abdominal examination, on inspection, the abdominal shape was concave, flanks were free, all quadrants move well with respiration. On palpation, abdomen is soft and non-tender, no guarding rigidity was appreciated, liver and spleen are not palpable. Percussion could not be done as the child was not cooperative. Auscultation, normal bowel sounds were decreased. Other system, respiratory system, cardiovascular system, and CNS examination was normal, and in the child was appearing drowsy. So my provisional diagnosis is that this is a case of severe acute malnutrition with acute gastroenteritis of viral etiology secondary to faulty feeding in shock.
Okay. Good, Anuja. Go for first slide.
Yes, ma'am. Yes, ma'am.
So he is a 2 months old child, no?
Yes, ma'am.
2 months old child has come with loose stools and vomiting. Okay.
Yes,
With
ma'am.
reduced urine output.
Yes, ma'am.
Okay, next. Next slide.
Ma'am, negative.
Yes, next. Stools with blood or mucus means what? He has both blood and mucus in stools or no blood and... Go back to past slide. No history of, okay. No history of blood and mucus in stools. Okay. What is the definition of diarrhea?
Diarrhea is passing more than 3 stools in 24 hours, which are watery, or
Yes.
they are consistency and volume.
Yes, good. Okay, next slide. Next slide. Okay, next slide. This the past history is the family history chart you show me.
Yes.
So this is one thing you people will do for pediatric history taking. Please don't write diabetes, hypertension, asthma, epilepsy. Routinely you do this in medicine. So don't write this either in the past history or family history routinely in pediatrics. Okay. Yes. Next slide.
Keep in mind.
Okay. Antenatal is uneventful. Next. Birth history. Now, what is your impression of birth history?
Ma'am, it was an institutional vaginal delivery, term delivery, and baby cried immediately, and birth weight is also normal. So there was no any birth.
Yes, very good. This means what? Her SAM has all started after birth. Can in utero malnutrition may be there? But this child, there is no in utero malnutrition, meaning there is no IUGR.
Yes.
Yeah. So this is a normal weight baby. Whatever the problem has occurred is postnatal.
Natal.
Yeah. Yes. Next. Yes. Next. We have discussed all this feeding part with the previous student. Next. Okay. How old is the child? He's 2 months old. No. Okay. Yes. Next. Now this child, what has happened at 2 weeks of age, mother has felt that her milk is not sufficient.
Yes, ma'am.
Suppose you are the treating doctor. She comes to you saying, my doctor, my milk is not sufficient for my baby, is crying all the time. What you will tell the mother? You are the treating doctor.
Ma'am, firstly, I'll tell her about the proper positioning and a proper feeding of the child, attachment of the baby while breastfeeding, to ensure that the baby is properly feeding, that proper attachment is there, and mother is positioning the baby in the proper position. Secondly, it may be due to baby's growth that they are demanding more. There may be starvation, like 4 milk. She's switching between the breast, so 4 milk only is consumed by the child.
Hello, how do you convince the mother that her milk is sufficient for the baby?
Ma'am, if we see serially, there will be weight gain, and the child will sleep adequately after taking the breastfeed for 1 to 2 hours, and the urine output will be regular.
So the mother will tell, my baby is sleeping, urine output is good, but why he is crying all the time? You have to tell, normally a child will cry for 8 hours in a 24-hour period in the newborn period. So you have to convince the mother. Now she will say, ma'am, now I want to start breastfeeding. Will you allow for breastfeeding now if she has totally stopped?
Yes, ma'am. I'll allow her, but she has to eat gradually by reducing the lactogen feeds and increasing the breastfeed.
Yes. How late you can restart breastfeeding?
Till 6 months, ma'am, because
till whatever time you can restart. There is no upper limit. Even 1 year also, 1.5 years also you can. How long mother should do breastfeeding?
For 6 months.
Exclusive. After that, breastfeeding should be continued for till what time?
1 to 1.5 years.
No, till 2 years. Till 2 years of age, she should continue breastfeeding. So anytime 1 year, 1.5 years, she can reinitiate breastfeeding. What will you advise the mother for while reinitiation? Any drugs you want to give? Galactogox, and what you will advise the mother? Apart from positioning, attachment and all that.
I'll advise her to do cup feeding when she is feeding, because she has started the lactogen feeds, so baby will be used to with that cup feeding. Then we'll reduce the lactogen feeds gradually, like for first 3 days. At the same time, when she gives lactogen feed, I'll advise her to give the breast feed for first 3 days. Every third day, she will increase the frequency of breastfeeding.
She should feed more frequently, because that stimulates prolactin secretion.
Right.
And any galactogox you want to give?
Yes, ma'am, I'll give.
Which name? Name some galactogox. Okay, continue. Next examination.
Yes.
Anthropometry.
Yes, ma'am.
Up to what age you do mid-arm circumference? In what age group you do mid-arm circumference?
More than 6 months.
Why you have done here? It is 2 months old child, no?
Yes, ma'am.
Why did you do mid-arm circumference?
To see whether the child is malnourished or not.
No, that malnourished. For that only, what age group you will do mid-arm circumference?
More than 6 months, ma'am.
Up to?
6 months to
6 months to 5 years. What is the age of your child?
2 months.
Here? Why did you do mid-arm? It was not required.
Yes, ma'am.
Yeah, you should go and read why it is done only between 6 months to 5 years of age. So, weight for length is less than -3 standard deviation. So, that's why you're making it a SAM. Yes, next. Head to toe examination. What are the signs of dehydration you have picked up?
Eyes, no tears are present, and sunken. And the oral cavity, the mucosa is dry tongue and lips, and skin turgor is more than 2 seconds.
Okay. And you said CRT is also more than 3 seconds. CRT is prolonged. So what's your diagnosis?
Ma'am, it is
your final diagnosis?
Probably a case of severe acute malnutrition with acute gastroenteritis of viral etiology, secondary to faulty feeding.
In shock. Okay, fine. Okay. So, how do you manage this child?
Ma'am, first I'll treat the diarrhea, and then I'll try to improve the nutrition by treating the severity.
No. What is the first priority? Which is the first thing you will treat in this child?
Ma'am, the shock and diarrhea.
Shock, not diarrhea, shock. So shock, how do you treat in this child?
Ma'am, I'll start fluid therapy. And
how much and what fluid?
Ma'am, ringer lactate or normal saline.
With dextrose. How much you will give?
Ma'am, by calculating the fluid deficit, I'll give that child.
How much? There is a protocol. That's why I'm asking.
Ma'am,
you should know.
100 ml per kg.
No. See, how that is for a normal child. How do you treat severe dehydration is different from a SAM child. How to treat dehydration? Plan C management in a normal child is different from treatment of shock in a SAM child.
Yes, ma'am.
So how do you treat?
Do
you know or you don't know?
No, ma'am, I have no idea.
Okay. How do you differentiate this shock from septic shock? See, acute gastroenteritis in a SAM child 2-month-old can also produce sepsis. So yes, you think this is hypovolemic shock or septic shock?
It is hypovolemic shock.
How to differentiate? hypovolemic shock from septic shock in this child?
Ma'am, the child is not febrile.
We say newborns, no, up to 2 months, they may not have fever. They will go for hypothermia or they may not have fever. So fever is not a strong sign in less than 2 months.
Okay, ma'am.
Okay, you can go and check that. Huh? Okay. Yeah. Do you know answer? Don't worry, it's little bit postgraduate level, but I just wanted to know if you know the answer.
No, ma'am, I'll read it.
Okay, fine. Thank you, Anudhya.
Good evening, everyone. I am Murugan, second year MBBS student from Cambridge Institute of Health Science and Research, Coimbatore. Today, I'm going to present a case which we came across in the pediatric OPD. Sorry, slide is not moving.
You take from the side panel.
Yes, ma'am. Yes, ma'am. 1 minute. Is it moving now?
Yeah.
Yes, ma'am. Master ABCD, a 2-year-old male child residing in Coimbatore, who came brought up by his mother, who is a reliable informant, presented with the complaints of fever and cough for past 5 days. The patient also had hurried breathing and chest indrawing since today morning. History of specific illness. A 2-year-old male child who is a firstborn child to the 3rd-degree consanguineous married couple and apparently well till 5 days back, presented with the complaints of fever for past 5 days, which was sudden in onset, high grade, intermittent type, reduced temporarily with medication. It is not associated with regulars. The fever is associated with wet type of cough and water nasal discharge for past 5 days with occasional post-acute vomiting. There is no diurnal or postural variation of cough. There is a history of hurried breathing and chest retraction noticed by the mother since today morning. It is associated with reduced feeding since morning. There is no history of lethargy, reduced activity, convulsions, bluish discoloration of skin, and there is no history of increased irritability, suck-suck cycle, and no history of reduced urine output, palpitations, edema over the back and legs. Treatment history. For the same complaint, the child was treated with oral medication at the nearby clinic and later on referred to our hospital with view of hurried breathing and chest retractions. Past history reveals that history of on and off of nasal discharge and noisy breathing for which the OPD basis treatment was taken and the symptoms is improved. There is no prior history of hospitalization or frequent nebulizations. The child was told to have a heart disease during regular wellness visit for immunization at 9 months of age. The scans were done and was advised for surgery, but the parent did not get the child operated due to some financial reasons. Antenatal history during first trimester, the mother is a registered and booked case at Karur Government Hospital. There is no history of fever with rash or painful swelling behind the ears, no history of radiation exposure, teratogenic drug intake, no history of excessive vomiting and burning inhalation. During second trimester, quickening was felt at 5th month. Anomaly scan was done and it was told to be normal. Iron and calcium tablets were started and continued throughout the pregnancy. There is no history of diabetes, thyroid diseases, no history of headache, blurring of vision. 2 doses of TT were given at 4th and 5th month. Third trimester, fetal movements well pursued. There is no history of burning inhalation, leak pervaginum or bleed pervaginum. Natal and neonatal history. The pregnancy was uneventful. The baby weighed 3 kg and it's a full-term normal vaginal delivery. The baby cried immediately after the birth, passed meconium and urine on the very first day. There is no history of jaundice and the child was on exclusive breastfeeding and was discharged on day 3. Family history, a 3rd-degree consanguinate married couple with two kids, a 2-year-old male boy who is our patient. And this is the diet chart. A perimorbid diet chart collected by 24-hour recall method found to be a 150 kilocalorie diet deficit, calorie deficit, and a 4 gram of protein deficit. Immunization history: the child was immunized up to date as per the national immunization schedule. The last question given was DPT and OPV, given as the age of 1.5 years. Developmental history: and the child attains appropriate development at the age, and there is no delayed developmental milestones. Socioeconomic history: the father is a farmer, the mother is a homemaker, and according to modified Kupsami classification, they come under the classification of class 4 upper lower class. Vital signs are found to be normal except the respiratory rate, which was 54 per minute, found to be tachypneic. And these are the anthropometric findings, and all these parameters are found to be normal. And head to toe examination: the baby is sick looking and irritable, consolable, and putting the baby against the mother's shoulder. Head on an examination, there is a mild frontal pausing. Color, texture, distribution of hairs are normal. The eyes looking normal, no pallor, no icterus, no evidence of vitamin A deficiency, and the ears and nose looking normal.
The mouth, neck, limbs, spine, back, everything looks normal and there is no edema. On systemic examination of CVS, inspector findings are normal shape and symmetry of the chest wall and no precordial bulge, no dilated vein, no visible pulsations, and the apical impulse seen over the left fifth intercostal space at the midclavicular line. On palpation, inspector findings are confirmed and there is a hyperdynamic apical impulse palpable in the left fifth intercostal space at the midclavicular line. There is no thrill, parasthenergy, and other palpable pulsations. On auscultation, S1, S2 heard. A continuous murmur, grade 3/6, best heard with the diaphragm of the stethoscope, the left infraclavicular area. On mitral area, tricuspid area, and aortic area, S1, S2 heard and there is no murmur. On pulmonary area, S1, S2 heard and the same murmur heard with a lesser intensity. On respiratory system examination, the child was found to be tachypneic and there's a subcostal retraction and intercostal retraction, and minimal nasal flaring is present, and accessory muscles of respiration are involved, and there is no grunting. Extensive flaps and rhonchi are here diffusely over both the lung fields. On abdominal examination, the liver is palpable 3 centimeters below the right costal margin and with a smooth surface and rounded borders. The liver span is 8 centimeters and there is no splenomegaly. From these clinical history and the physical examination, the most probable diagnosis would be a cyanotic congenital heart disease, which is most likely to be PDA associated with the bronchopneumonia and with cardiac failure in sinus rhythm. And these are my investigations.
Wait.
Thank you.
Okay. Yeah. Go for your first slide.
Yes, ma'am. 1 minute.
So, what is your impression of the first slide? What is the child having?
Ma'am, at this stage, we can conclude that the child having some lower respiratory tract infection.
Yes, good. Next slide. Okay, next slide.
On this slide, I just described the fever, the types of
next
fever.
slide. Next slide.
And this side, the cough, the water
Slide.
these are the
Next
past
slide.
findings.
Next slide.
These are the negative histories I ruled out.
Okay, now, yes, next slide.
Yes, ma'am.
Okay, yes, next slide.
Yes, ma'am.
Now, this child in the past history came to know that he is having a heart disease.
Yes, ma'am.
Now, when
That's
you
why
go back, a known case of heart disease patient comes to you with hurried breathing and chest retraction. Apart from pneumonia, what else you want to keep?
heart failure, ma'am.
Heart failure you want to keep. So,
Yes,
what does pneumonia and heart failure indicate? In which type of CHT it indicates?
Ma'am, it indicates a right to left shunt congenital heart defect. Sorry, ma'am, left to right shunt congenital heart defect.
Oh, it indicates left to right shunt, right to left shunt, or it has some relation, something in relation to pulmonary blood flow.
Yes, ma'am. There is an increased pulmonary load. That's why there's an extraction of the fluid and causes this recurrent infections.
So this increased pulmonary blood flow can occur both with right to left or left to right shunt. Tell me some common left to right shunts which will present with pneumonia and failure.
PDA, then ventricular septal defect.
So I will ask you the same question which I asked to another candidate. AST, is it left to right or right to left shunt?
AST is left to right shunt one.
So though AST is left to right shunt, like VSD and PDA, why it doesn't present with pneumonia or CCF? Does it present with pneumonia and CCF? ASD?
No, ma'am.
No. Why?
Ma'am, because the both atrium contacts simultaneously, so there is
both
no
ventricle also contract simultaneously.
I'm not very sure about that.
Okay, no problem. Yes, continue. Next slide. Next slide.
Yes, ma'am. Antenatal history.
Okay. Tell me some antenatal insults which produce PDA.
Ma'am, the second line, no issue of fever with rash or painful swelling during the year. I just asked this history to rule out congenital rubella syndrome because this produces a triad manifestation which includes congenital heart disease, which is the PDA is most common in congenital rubella syndrome.
Tell some teratogenic drugs which produce PDA.
Teratogenic drugs includes phenytoin, alcohol, and
Alcohol is not a drug. Phenytoin can cause PDA.
Phenytoin can
Yes, next slide.
valproate.
Next slide.
Yes,
Next slide.
Yes, ma'am.
Okay. Next.
Yes, ma'am.
Next.
Yes,
Okay. Okay. Go for examination.
Yes, ma'am.
Previous examination. Now,
Yes, ma'am.
what is the impression of your inspection?
Ma'am, from this, the apical impulse is at the normal location, and there is no. In
Age
palpation,
of the child is how much? Age of the child?
2 years, ma'am. 2 years.
2 years. What should be the location of the apical impulse?
For 2 to 5 years, it should be in the 5th intercostal space at mid-clavicular line, ma'am.
4th intercostal space. After 3 years, it will start shifting. 2 years, it should still be in the 4th intercostal space. It's slightly shifted down. Okay. Next.
On palpation, we found a hyperdynamic apical impulse, ma'am.
So what does it indicate? Is it normal or abnormal?
Abnormal, ma'am.
So what does hyperdynamic apical impulse indicate?
It indicates volume overload, ma'am.
Yes, good. Tell some conditions, CHTs which produce volume overload.
PDA, and then aortic, the mitral and tricuspid regurgitation, aortic regurgitations, pulmonary.
Most common.
Mitral regurgitation.
No. You have left out the most common lesion, which produces left ventricular volume overload. You said PDA, MR, AR.
Yes,
VSD. VSD
okay.
produces volume overload. Next slide.
Okay. Auscultation.
Continuous murmur.
Yes,
So where do you get continuous murmur?
In patent ductus arteriosus.
Patent ductus. Tell me some other differential diagnosis for continuous murmur.
Aorta pulmonary window.
Yes. How do you differentiate PDA from AP window?
No, I couldn't replace this.
No problem. What are the other DDs for continuous murmur apart from AP window?
I'm not sure.
No problem. You're second year student. You're answering well for a second year student. What is the difference between to and fro murmur and continuous murmur?
Continuous murmur starts from S1 and on S2 rises a peak and then wanes, ma'am. To and fro murmur, it has it increases when reaching both the heart zones, ma'am.
It doesn't mask S2. It doesn't peak at S2. There is a systolic murmur and an early diastolic murmur.
Early diastolic murmur.
Yes. Continue. Next.
Respiratory system findings
is normal. Okay. Next.
Then,
what's your diagnosis?
Acyanotic
pointers for failure in your patient.
Ma'am?
What are the pointers towards failure in your patient?
Yes, ma'am. The first thing is the child is consolable on putting on the shoulder of the mother. So this indicates could be a insufficiency of the heart.
That is a very soft sign.
Yes, ma'am. Hepatomegaly is there, ma'am.
Yes. Next.
And hepatomegaly is there.
How do you differentiate? He has pneumonia, pushed down liver from hepatomegaly. He has tachypnea, he has pneumonia, hyperinflated chest can push down liver.
Yes,
how do you differentiate a push down liver from a true hepatomegaly?
Tidal percussion. Tidal percussion.
Okay, leave. Hepatomegaly, what are the other pointers towards failure in this child? Does he have a subcrest cycle?
No, ma'am. There is no history of subcrest cycle. This is I think this is a mild evolving failure. So the child doesn't have any frank symptoms. Only this thing is stands there.
Okay. Along with this, you should write whether there is pulmonary hypertension. If it is not there, also you should write no evidence of PH, no evidence of infective endocarditis. That should always be there in your CHT diagnosis. So now coming to management, this child you have done echo and you know it is PDA. Now parents don't have money for surgery. What happens in an untreated PDA if you don't operate? Last question. And they will say, doctor, another 3-4 years we will get money and then we will operate. So what all can happen in this 3-4 years?
Untreated PDA may lead to recurrent respiratory infections.
Next.
Then
we'll come, doctor, for recurrent respiratory infections. We'll come for treatment. Anything inoperable can happen?
The child may fail to thrive as because
yes. Anything more serious?
The child may develop right to left shunt.
They can go for pulmonary hypertension and ice.
Yes, ma'am.
Okay, thank you.
A very good evening to one and all. I'm Anushree, fourth year MBBS student from Kodagun Institute of Medical Science. Here is a 4-year-old male patient named Master KMN who hails from Madikeri. Informant is mother and it's reliable of birth order 1. He mainly presents with the chief complaints of loose stool since 4 days, pain abdomen since 4 days, and vomiting 2 days ago. History of presenting illness. Patient was apparently normal 4 days back. Then he started complaining of loose stools of 8 to 10 episodes per day. Watery in consistency, occasionally blood stained, greenish in color, non-foul smelling, and relieved after medication. Pain abdomen since 4 days, insidious in onset, gradually progressive, present around the periumbilical region, non-radiating, dull-ish type of pain, relieved after medication. Vomiting 2 days back with 1 to 2 episodes per day, contains saliva, not bile stain, blood stains, and non-foul smelling. No history of decreased urine output, abdominal distension, fever, lethargy, loss of appetite, hematemesis, melena, hematuria, joint tenderness, jaundice, gum bleeding, edema, or fatty stool. Antenatal history, there was regular antenatal visits with iron and calcium and folic acid tablets taken. 2 doses of TTD vaccine is done. Anomaly scan was done and found to be normal. There was no any antenatal events. Birth history, normal vaginal delivery. Full term, birth weight of 3.5 kg, cried immediately after birth. Neonatal history, no history of neonatal jaundice. Healthy, active baby, no history of NICU admission. Breastfed immediately after birth, exclusive breastfed for 6 months. Growth and developmental history, gross motor developmental milestones were appropriate for age. Nutritional history, there was deficiency of 265 kilocalories and 33 grams of protein. Immunization history is up to date. Family history, no similar complaints in the family and born to a non-consanguineous marriage. Socioeconomic history, the child belongs to class 4 of socioeconomic status according to modified BG Prasad classification. Father's occupation is farmer and studied till SLC, lives in Kacha house but no overcrowding and good ventilation present. Water supply from well, drink filtered water, no nearby drainage, and they use dustbin. Past history, mother gives a history of easy bruising and ecchymosis, hematoma of left elbow after a fall 1 week ago, no similar complaints in the past, no history of blood transfusion. Summary, a 4-year-old boy born to a non-consanguineous married couple belonging to the class 4 of modified BG Prasad classification with a normal immunization and developmental history with a deficiency of 256 kilocalories and 33 grams of proteins, presents with complaints of loose stools which was blood stained since 4 days, abdominal pain since 4 days and vomiting 2 days ago with a significant past history of easy bruising and ecchymosis and hematoma of left elbow since 7 days. General physical examination oriented to time, place, and person. Vitals, pulse rate of 104 beats per minute. Respiratory rate of 24 cycles per minute. Temperature afebrile. SpO2 of 96%. Capillary filling time less than 3 seconds. Head-to-toe examination. Head is normal. Eyes, pala was present, no icterus. Ecchymosis was seen just below the left eye. Nose and nasal cavity normal. Ears and oral cavities were normal. Neck was normal. Limb swelling around the injection site in the left wrist joint. Skin fresh bleeding at the injection site. Anthropometry was normal. Bilateral equal entry. Normal vesicular breath sound. Conscious and no focal neurological deficit. Genitourinary system. External genitalia appear to be normal. Per abdominal examination, inspection, shape of abdomen normal, skin over the abdomen is normal, umbilical position is central and inverted, no engorged vein, visible pulsation, hernial orifices are intact. Palpation soft and non-tender, no local rise of temperature, no organomegaly, percussion, liver dullness with clinic dullness felt, auscultation, bowel sounds present. This is a picture of the patient. Provisional diagnosis, acute dysentery to rule out coagulation disorder. Thank you.
Okay, Anushree, go to your first line.
Yes, ma'am.
Hello.
Yeah, go to your first slide. Okay.
So first
Second, next
slide.
slide. Next slide. So he has come with loose stools, pain, abdomen, and vomiting. Next slide.
If possible, keep your video on now.
Okay.
It's on.
Now it is blood stained, you said. So what are the most common causes for dysentery in children?
It's the bacteria dysentery.
Bacterial cause. We are not hearing you properly. Bacterial cause, which bacteria?
Shigella, ma'am.
Shigella, yes. Now you said stools are greenish in color. Where do you get greenish stools?
If it is bile stained, like if there is obstruction
Bile will be there,
bile
no?
and,
if it is bile only, you will get pigmented stools. You don't get green. Normally bile will be there, no? If you don't have bile, then you will get ecolic stools, whitish, clay colored stools. When will you get greenish stools?
there is Pseudomonas. I'm not sure.
No. Okay. Okay, continue. Next slide. Are you finding it difficult to move the slides? Then we'll discuss. Okay. Now, yes, vomiting, you should write whether it is projectile or non-projectile. That thing only is not there. So any vomiting, you should mention projectile or non-projectile vomiting. Okay. Next, he doesn't have any features of dehydration and no bleed from any other sides. Okay. Yes. Next. Okay, now these are all normal. You can go to the history that he is having recurrent episodes of some bleeding, you said, no? That go to the last slide of history. Yes. No. Next slide. Mother gives history of easy bruising and ecchymosis, hematoma of left elbow. So what do you think? He has a platelet blood vessel disorder or he has a coagulation abnormality?
Based on the it's just like because platelet.
So it looks like a coagulation
manifestation like perfusion.
Okay. Yes, correct. Which is the most common coagulation abnormality you see in pediatrics?
Based on the gender, it's a male gender, so most common is hemophilia.
How early hemophilia can present?
During toddlers, like when they start walking, that time we'll start seeing the presentation.
Yes. Okay. What are the types of hemophilia you know of?
There are 3 types of hemophilia, ma'am. Hemophilia A because of factor A deficiency, hemophilia B because of deficiency, the factor deficiency.
Okay. What is vascular hemophilia?
No idea, ma'am.
What is parahemophilia?
No.
Okay, no problem. So you said ABC, no? Which is most common of all this?
Deficiency.
Okay. So is this the first time this child is having hematoma in the left elbow, or he has been having it from before?
Like since they were aware of the situation, so they didn't bother about it. But since he had this vomiting and loose stools and all, that's why they were concerned about it more than this. They just thought this is a normal thing, and they never came to a doctor.
Yeah, so that's what I'm asking. So that means he has been having this swelling of the elbow from a long time.
Since 1 week ago, when he had a fall, he developed this hematoma. They go on a few months.
What do you mean by target joint in hemophilia? Target
joint. It's mainly because of the of the blood in the joints.
We are not hearing you also properly. It's okay. Yeah, go to the examination slides. Go to the bleeding part, then diarrhea, then dysentery, no signs of dehydration. So go to the bleed that slides on bleeding? Swelling, some slides you had, no?
Okay.
He's having a swelling around the injection site and fresh bleeding at the injection site. Okay. Okay. What are the other conditions for joint swelling? DD is for joint swelling.
Joint swelling it be inflammatory because of it can be arthritis or rheumatoid arthritis.
Then
injury trauma which has the
trauma, arthritis. Next,
cellulitis, ma'am. Any inflammation of the muscle around the joint.
Next.
Synovitis.
Yes. Next.
Arthritis, ma'am. Rheumatoid arthritis.
No. Rheumatoid or that over. Okay. Next. How do you confirm your done? Go for your final slide. What is the mode of inheritance here? Hemophilia?
Autosomal recessive, ma'am.
Huh?
X-linked. Hemophilia is X-linked, ma'am. X-linked
So
recessive.
what happens? What is the typical feature here?
In hemophilia, ma'am.
In X-linked recessive inheritance, what is the typical feature?
The female carrier and the male child are usually prone to get hemophilia, ma'am.
Good. So when a female gets affected in X-linked recessive inheritance, usually females are carriers, they don't get affected.
Ma'am, when the early child then there is a chance that manifest, ma'am.
Okay. We are not, I didn't hear this properly. Can you tell once more?
Hello.
Yeah.
Hello, ma'am. When both the alleles of the carriers are present, then the females will manifest, ma'am.
When is that scenario?
When both father and mother, when the mother is a carrier and father, the chances of getting the hemophilia is more, ma'am, in female child.
Other common causes for this one? What is lionization? You heard of lionization?
Sorry, ma'am?
Lionization.
No, ma'am.
And in Turner syndrome also you can get. Okay, thank you, Anushri.
Yes,
thank you. We are also not hearing you properly. Thank you.
Hello. Okay. Thank you, ma'am.
Thank you, Anushri. Now all finalists are done, ma'am.
Yeah.
I thank you very much for your precious time, ma'am. It was really a power-packed discussion where all exam-oriented important questions are covered. It was broadly a brief discussion for all users, ma'am. All questions are covered in single session.
You could have little bit brought down the number of cases, then we could have discussed a little bit more in detail. Otherwise, actually, they all have presented well. You want me to tell the results now or you want me to send or what?
No, ma'am. You announce the winners now only, ma'am.
Yeah, just give me 1 minute. I will just count.
Okay, ma'am.
Meghana, until ma'am announces results, can we ask the participants, any of them, as to how they felt coming up here and presenting the case? Like when we saw, anyone would have been at least a bit of nervousness we would have had, but all of them were equally confident enough to come up and present it in such a nice way. No one had any hesitation as such. So participants, anyone would like to share your experience?
Yes, sir. Can I share?
Yeah, Murugan.
Ma'am, actually, I'm a second year student, so I thought of I had more fear to come and present over here because all the students are fourth year students. So what I thought is like, let me come here and participate, no problem. Let me learn from my seniors. That's what I thought. And in our college, we don't have seniors, so I came here and learned from the 11 other seniors and from greatest experience, ma'am. And I came to know many things today, and I never forget this incident. Thank you, White Army, for this wonderful opportunity. I hope we may be in constant touch with White Army, and upcoming days will be much more useful for learning. Thank you so much.
Murugan, we too appreciate you as well. Being a second year, you've come up to present the case. Like, takes a lot of efforts as well as willingness to study. So doing mistakes is fine, but at the end, learning is important. Correct?
Yes, sir.
So
thank you, Murugan. Yes, sir. I actually want to thank my mentor, Dr. Prabhu Vikas, who take effort and teach me these things at this platform. Thank you, Prabhu Vikas, sir. Thank you, sir.
Yes, thank you, sir. Anyone else would like to share their experience? Any of the participants? Akshay, would you like to share?
Yeah. Harshita?
Okay. Harshita has unmuted herself. Harshita, would you like to share your experience?
Yes.
Any few words? Yeah.
First, I would really thank ma'am for giving so much of her time, and she was equally patient with all the contestants and participants. And it was a great learning opportunity because we could revise so much in such less time, even by listening to the other participants. So I think it's a really great initiative. Thank you.
Thank you, Harshita. Akshay?
Okay, shall I announce?
Yes, ma'am.
And students want to give some feedback, then we'll wait. Otherwise, I'll announce. Okay, for me, it was actually very nice. I had a good time interacting with the students, and even I learned from all of you. And actually, it was a very good presentation, as Ashray told. You were all very confident, and please carry this confidence always in the exam. No, as examiners, we will assess you we'll get to know in the first 2-3 minutes, and that assessment is mainly based on your confidence. If you are very confident, then half the battle is won. And what I saw was all of you all were very confident. Please carry that. And where will you get that confidence is by studying and seeing the patients in the ward. So please do these two things and you will automatically get the confidence. And I thank the White Army team for giving me this opportunity to interact with you all. And actually, it's just one mark difference between each student. It was very difficult for me to calculate the top first three, to take the first 3 students. So I will go in the reverse order. Congratulations to Nisarga Kini, who presented the recurrent pneumonia case. I didn't write the college from where they had come. Nisarga Kini is from which college?
BGS Medical College, Bangalore, ma'am.
Bangalore. Okay. 3rd place. Congrats, Dr. Nisarga. And
thank you very much, ma'am.
Thank you. And 2nd place goes to Ritodeep Nandi, who presented ITP case. I think he was from
Medical
Calcutta.
College, Kolkata, ma'am. Kolkata.
Yeah, good. He presented well. So Ritodeep.
Congratulations, Ritodeep.
And 1st place goes to Karina Ann Lobo. She presented thalassemia case. And actually between the 3, it's only 1 mark difference. She got 1st place. She is from which college?
She's from Father Miller Medical College,
okay.
Mangalore.
Congrats, Karina.
Congrats, Karina.
Okay. Thank you. Thank you, Ashray. Dr. Meghana, thank you.
Thank you so much, ma'am. I think so. Even the participants are all blessed to have learned from you, ma'am. Yes, ma'am. Being such a senior faculty, and you've taken exam throughout for past so many years, ma'am. So all the participants as well as us watching are all blessed, ma'am. Thank you so much, ma'am.
Thank you. My pleasure. Thank you.
Any feedbacks you would like to give, ma'am, apart from the number of cases we tried to reduce, ma'am, but that there were so many participants and all of them were equally good. So we tried to pick all the different types of cases in the end, ma'am.
Yes, I think it was okay. But if you had the timing, you could have little bit, even then we couldn't, because these are exam cases. No, I think 5 + 10 was okay. It was nothing specifically, I didn't find anything drastically to be changed in the presentation.
Okay.
Thank you.
Yes, ma'am. Thank you so much, ma'am. And participants, thank you so much. Like there's nothing like winning or losing. Coming up here, participating and getting to learn from ma'am, that itself is equal to winning. So congrats to all the winners and all the participants as well. And please do come up and present new cases to ma'am or any of the other senior faculty members who's eagerly come up to teach us. So we are expecting more such participation in the coming days. Thank you guys. Thank you so much. And thank you, ma'am.
Thank you.